Okay, so you are getting them anyway.
I get them, and it's a total mess because the IT system is still owned by the bankrupt company. So there must be some hiccup. It's all going to change in the next couple of weeks. But I get all the messages.
Okay, I'm happy now.
Me too. Awesome team. I had just seen Ramesh in Goa.
How was Goa?
It's an incredible, interesting place, I have to say. I was...
Did you get a chance to go around it? Oh.
Yeah, I took one morning off and went really into the island. There's another island next door. I had a local host who was showing me. I didn't realize this, that island is 400 years of Portuguese history till 1961. It was Portuguese,
Yeah.
and then it was naturalized into the Indian territory, right? But you have, as the host said, people that are a little bit older than I am who grew up Portuguese speaking, high school Portuguese, and then learned Indian as a second language, Hindi as a second language. And I didn't realize that. That was culturally quite interesting.
Yeah,
it was a typical fisherman's town, right? They have lots of fish and they make port wine and interesting cookies that are just like the ones in Lisbon. I mean, it's stunning.
How many people were there, Ek? How many people were there? How many parties?
350, I'd say. Not a big meeting, but it was nice.
Very
Yeah.
good.
I heard there were 3 meetings in India at the same time. Or
Yeah, in Rajkot, there was a meeting just a week previous to that, and then I don't know what was after this meeting, but there were meetings together.
Yeah, and Kiki was not happy. He had sort of unfortunately picked a date where the Indian Society met somewhere else. Basant wasn't able to come. Lots of people just couldn't make it, right? And you know how he is. I mean, oozing out enthusiasm, and then the practical side is sometimes falling short a little bit.
There are many meetings around the world nowadays. Every second day, there are 2 or 3 meetings, yeah, on top of online.
Pablo, is Abu sir coming? You changed the order?
Yeah, he told me that he was driving back to the lab and he should be on time, but just in case he's not, maybe as Vlad is here.
Yeah, Vlad is
Vlad
here.
could be.
Whatever.
Who from the gang is coming to the Yashagil meeting and the AANS in Boston? Imad, you are coming, right?
No, I canceled my trip to there. I could not.
Oh, I'm sorry.
Yeah.
I keep you guys posted. Maybe I can see whether there's a link. There are some interesting talks on global neurosurgery.
Well, I heard that overcrowded with presentations, and they are giving some people 3 minutes for a presentation.
Wow, really? Well, I have unfortunately rather little influence on this, but next time I will. Trying to set up a meeting for all of us in 2026, maybe in Boston, okay? I keep you posted. I'll let you know.
Yeah.
Boston is a beautiful city. It's a nice city. But I thought Giovanni is going.
That would be nice.
Yes, I'm going.
Oh, good.
I don't know if I can get in time for the Yashagil meeting, but definitely at WNS I will be there.
All right, we'll connect.
I try to get on the day before, 2 days before, because this is before there is the Yashagil meeting, and after there is global neurosurgery, and after is the WNS.
Right.
That's what I heard.
But I understood they changed the venue for the Yashagil meeting.
Yeah, there were too many people.
They put it back to the hotel.
And they really are giving 3 minutes lecture?
3 minutes.
That's ridiculous.
For each, and I was assigned a discussant for 3 minutes for a talk of 3 minutes. But I was put as a chair for a 2-hour session, but I have to apologize. And
3 minutes is enough to say thank you for invitation and goodbye.
For the attention. Can you imagine Keki on that?
Well,
Or Majid.
Keki's meeting was 4 minutes.
Or Majid.
yesterday.
Hello, everybody.
Hi, Victor.
Victor.
Hi, Abu sir.
Nice to see you.
Hi. Nice to see you too.
I'm very happy because of
We
the
can't
book.
see it. We cannot see it, the book. Yeah, you holding it, but we can't
Put it
see
in
it.
front of you.
Keep it in front of you, otherwise you...
So everybody got his copy?
I
I'm
haven't...
very happy, very
Yeah.
happy to get my
I'm
book.
still waiting for it, Imad. I don't know what happened. I was thinking about it today to write to Madonna to find out what happened.
Yeah, you are supposed you are on the list to receive it.
I will write to her again.
Yeah. I
I
think
must
all
say, I
others
just
would like-
ordered my second copy.
Wish you.
Well, I ordered 10 copies to give it to the fellows around me.
Hi, Mauricio.
You
Yeah.
got
Hi,
the discount?
can you hear me?
Imad? Hello.
Thanks.
Hello.
Hi, Brad. Hi,
Hello.
Mad.
Hi, Francisco. How are you?
Fine, fine. Thank you.
Good.
So Ramesh, Abu Sir is here, so we should keep the Abu Sir, Mauricio, and Vladimir.
Yeah,
And Henry is in the
that
car.
sounds
So,
good. Yeah.
Yeah. Still time.
so YouTube is open also. And we had 450 people registering. And I will give you the numbers after.
Very good.
Not bad.
Well, as long as we still have 1 minute, I think, or 2 minutes, I just want to inform you that the first fellowship for the research is now with Matthias. They are publishing video sessions on the international neurosurgery shortly. And we have another candidate, I think, thanks to Pablo, you have submitted his name. He sent me the CV. I'm waiting for Igor to, I hope that we have to launch him soon for this year. Okay.
Leonard from Malawi.
He's very good person, yeah.
Very nice.
Good. And I encourage everybody who has an idea, have somebody in mind you want to support for a fellowship, 3 months or 6 months, let us know so we submit it to the colleague, whoever can adapt him in his lab.
Thank you, Matt.
Thank you.
Maybe we should start.
Ramesh.
Okay, we'll start off. Once again, the second part of the neuro-oncology sessions. It was a fantastic session last time, the previous one we had. And we have the new stars for this session, starting with Professor Abu Sugangor. Are you ready to start your presentation, Abu sir? Yeah, we can see your presentation. You can go ahead.
Hi again.
Your voice is not coming through for some reason.
Did you hear me?
Yeah.
Yes.
Okay. Yeah, I will talk about the interhemispheric approach. When we talk about the interhemispheric approach, we must talk about the bridging veins and the suprasagittal sinus. We always should care about these bridging veins and to preserve them instead of sacrificing. And when we go forward, we can reach the Falcian surface, and also we can remove the false tumors like meningiomas and the lesions located in the medial side of the frontal, parietal, and occipital lobes. And also we can reach the corpus callosum, and transcallosally we can reach the lateral ventricle. And when we go beyond, we can reach the third ventricle via transcallosal interforamen cell. Also from foramen mono, we can reach the third ventricle. Transcallosally, we can reach the all part of the third ventricle and the lateral ventricle. And also in posterior interhemispheric way, we can reach the temporal surface and the mesial temporal lobe structure and also atrium. I will show some cases and also P2 brain. As you see, in interhemispheric way, we can reach all medial surface of the brain and the callosum, and the transcallosal, we can reach the lateral ventricle and also third ventricle. And also we can reach the atrium in posterior interhemispheric way. As I said before, one of the most important thing in interhemispheric approach, the bridging veins, we can change our craniotomy it depends on the localization of the bridging veins. Like that, if you preoperatively, if you determine the localization of the bridging veins, you can choose your localization of the craniotomy and change. For example, these kind of craniotomies are always used for transcallosal approach to reach the third ventricle and lateral ventricle. Why we mostly use the interhemispheric way? Because the most of the eloquent areas and the important white matter structure located in the lateral surface of the brain. For example, there's the atrial lesion, cavernoma. The optic tract is located lateral to them. As you see, in lateral surface, the optic tract and the arcuate fasciculus is located. But if you go interhemispherically, you only pass through the callosal fibers and can reach the atrium. For example, the atrium meningioma, we perform transfocal approach, but the patient faced with the visual deficit. Because of this, with Professor Ture, we described Rashagil described the Pineal approach to the atrium, but we described the start to use parieto-occipital fissure to reach the atrial lesions. As you see, interhemispheric, we go and open the parieto-occipital fissure, and this is the intraoperative views. And with ultrasound, we can describe the all falci. And this is the postoperative view. We can preserve all optic tracts and the lateral surface of the brain. Even it can be large, it can be removed in the interhemispheric approach. And also there's a lesion located in the medial part of the frontal cortex. And you can see the cortical spinal tracts and the motor area around these lesions. And also in this kind of approach, transcortical approach can be used, but as you see, as you know, the homunculus located, all motor areas located the lateral areas, but it finish is the cingulate sulcus. And also, if you go transcortically, almost 50% of cases can have motor deficit. Because of this, we start to use interhemispheric transcingulate sulcus approach. Only cutting some callosal fibers, we can reach this kind of region. Yes, it is difficult to go interhemispherically and go laterally, but we did the same things in the interhemispheric posterior, transposterior occipital fissure approach. As you see, this is the patients with the motor cortex cavernoma. Interhemispheric lay. we go in and define the cingulate sulcus and open the cingulate sulcus. We remove the lesion. In preoperative and postoperative views. And also you can use in glial tumors. And also you can use interhemispheric approach related with the lateral ventricle. There's the cavernoma located the frontal horn of the lateral ventricle. I always use the lateral position to use gravity and open the hole above the sagittal sinus. As you see, with gravity, you don't need to use the retractor. And after opening the corpus callosum, we can reach the lesions and can remove. And mostly this interhemispheric approach mostly used for colorectal, third ventricular colorectal. As you see, they always use the similar craniotomies. The ultrasound is one of the most important things when transcallosal approach or transcarsal approach, because it is important to select the correct place for callosotomy. He always use the pathway between the both callosal arteries. As you see, the cotton guided ultrasonography. We selected the right place to open our callosotomy. Then dissect the choroids from surrounding tissues. And it was bigger than our callosotomy site. After removing the choroids, sometimes we open the third, we did third ventriculostomy. This is the postoperative view. This is our callosotomy site. And also in third ventricular tumors like craniopharyngiomas, we can use interhemispheric transcallosal approach. After opening the corpus callosum, we entered the third ventricle from foramen mayor and removed the tumor. The postoperative view of the craniopharyngioma. And also, you can reach most of the areas related with the thalamus and the globus pallidus. You can see the lesions located with the thalamus and the globus pallidus. We will go to transcallosal, anterior limb of internal capsule to reach this lesion. After opening the corpus callosum, we selected right place to enter the lesion. And after entering, it is easier to remove was the plastic astrocytoma. This is the postoperative view. You can see our callosotomy site and the trajectory. And also, you can use a contralateral approach, interhemispheric contralateral approach. For example, for this patient had two lesions in frontal broca and the interhemispheric medial frontal area. Because of this, to reach both lesions in the same operation, we select the contralateral interhemispheric approach for the lesions located the medial side of the frontal lobe. After opening the valve, you can reach the contralateral side and remove the tumor. And after removing the medial frontal area, we'll also remove the lesions located in the broca. This is the postoperative. We went the contralateral interhemispheric approach. The lesions located the medial frontal area. And this is our laboratory. All the anatomic structures, anatomic photography coming from our lab. Whenever you want, you can visit. And also, you can use the technologies to determine the bridging veins and all arterial structures preoperatively. And also, you can reach all our models via neurosurgical atlas. Our 2D and 3D models with labels. And we will publish soon these high quality 3D models. You can find any details. I want to thank all my mentors and fellows. Thanks for listening.
Thank you. Thank you, Abusa. That was great, very versatile. And for any lesions around the midline and including intraventricular lesions. The one thing which I want to ask you, whenever you plan these operations, are you willing to switch the side if you find that a vein is in the way and you cannot really sacrifice it? Will you be willing to go across and come from the other side?
Yes, for example, for ventricular tumors or third ventricular tumors, we can change the side of, for example, we can use the right side or the left side. If there's a bridging veins through our trajectory, we can change our side. Also, localization of the craniotomy. But always try to preserve all bridging veins without that infection.
I think it's quite obvious that we need to know the position of this draining veins well in advance through the MR venogram. I suppose that's what you normally use. Do you use angiograms or just MRV?
MRV.
Yeah. So if I think that in terms of your position, many of the procedures you did were that they were on the side. You put the side you wanted to retract on the lower side. So I think that's why you have to get that position of the vein correctly. Otherwise, if you have to go across, it'll be very difficult to switch the sides at that time. So it's important to get the venous drainage accurately beforehand, before positioning the patient on the lateral side of you, right?
Yes. It is important to detect all bridging veins preoperatively.
Right, Pablo.
Sir, thank you. It was excellent, full of anatomy and dissections, very good material. And I realized that in most of your OR cases, the head is completely lateral in most of them. How do you choose in between completely parallel interhemispheric fissure to the floor or slightly oblique? Is that something that you...
I was using the lateral, but nowadays I am using an oblique position. to avoid the pneumocephalus, because when you use the full lateral position, it is difficult to avoid the pneumocephalus. But if you use a bit oblique position, you can avoid the pneumocephalus.
So that's supine and
Yeah.
just rotating
Oblique,
and
yes,
elevating.
a bit on.
That's what you do. Okay.
Yes, sure.
And just curiosity, which was the pathology of that tumor that had a medial frontal glioma and inferior frontal gyrus
GBM,
glioma?
multifocal GBM.
Okay.
Vladimir?
Yeah. Abudar, in the drawings you have shown the bone cut run directly along the superior sagittal sinus. Is it true, or you do not go to the opposite side?
No. I don't go to opposite side, directly to the Burhorst above the sagittal sinus.
Okay. And then next thing, some of the lesions you have shown would be much better to be approached from the opposite side. The sulcal approach would be exactly the same as you are doing, but from the opposite side you get a direct vision and you came along the long axis of the lesion. So it's always far more comfortable than going a little behind the corner.
Yes, I always think to use contralateral approach, but also Pablo knows it can be a bit difficult while you are cutting the false venous bleeding. And also I always handle the chance to go transcortically. If there's problem while interhemispheric way, I can reach the same lesion from transcortically. I haven't done before, but I always want to this chance in my pocket. If there's problem interhemispherically, I can go transcortical. Because of this, I want to use the ipsilateral side.
And any further comments?
I have one comment.
Yeah, Imad. Go on.
What is the patient outcome regarding cognitive function and involvement of the pharmacy during these approaches? Especially these approaches you have went from the ventricle to the intraparenchymal lesions. There were 2 or 3 lesions you have attacked. They were eccentric, and you went yet through the ventricle to connect to this lesion and take them. How was the outcome of the memory and all these things?
I don't have the detailed neurophysiological examination after these operations, but these patients with 2 lesions from the large medial frontal and the Broca, he's writing books. He's writing books about his professionality without losing any anything about cognitive function.
Do you leave a ventricular drain on these cases?
No. I am waiting after removing the tumor at least 30 minutes, and but they don't use a ventricular drainage.
Ek, you wanted to ask something?
Yeah, one final question regarding the craniopharyngioma that you showed, and you did interhemispheric transcallosal. I like that approach because the retrochiasmatic component of the tumor is much better visible than if you do it endonasally. But the argument in the field right now is a lot of people say you should always try to go through transsphenoidal first. What is your take on this? I'm a fan of open microsurgery, and I go translamina terminalis. I don't like the corpus callosotomy. But have you thought about differences, and what is your decision tree?
I learned these surgeries from Professor Tu and Necmettin Pamir. Because of this, I always go transcranially for craniopharyngiomas. I feel always more comfortable than the transnasal. I also do endoscopic transnasal approach, but not for the craniopharyngiomas.
But in my view, craniopharyngioma should be first tried through endoscopic route first, because you will be surprised that even though it is retrochiasmal and might find that some of it may be attached to posterior circulation vessels, sometimes it may be you can achieve a great resection endoscopically because it's a direct route. So in my view, the craniotomy approach is a standby option. It's a different opinion, but that's what I normally do.
But Ramesh, if you think about the tumor being behind the chiasm, if you come in from below, it is really incredibly hard to get to this often calcified portion that sits right on the backside of the chiasm. So for me, the decision tree was often if the tumor is small and more in the cella or just retrocellar and the chiasm is elevated, I would go transnasally. But the minute there's a suprachiasmatic component, or even when it sits purely intraventricular, I don't even try to go through the nose. I would totally agree with Abuza that the transcranial approach is very safe, gives you total control over the field. And I don't want to pull a larger tumor that is very adhesive through the nose, and then as you pull it down, you don't know what the part of the hypothalamus is you're really pulling on, right?
Yeah, it is about, obviously I agree with some of the aspects of which you mentioned, but when you have tumors extending into the above the cellular retrochiasmal area, one may have to maybe move the pituitary gland to one side, or you may have to push it, or even drill off the posterior dorsum cella and posterior clino to have a good view, especially if in the interpedunculaire cistern. So yeah, so I agree. I think it's a different view.
I may give a comment on this one. I have to concord what X said. I was craniopharyngioma, especially the heavily calcified one, should not be attempted from below. You are putting patient at risk. You are just emptying a cyst rather than taking a lesion capsule. And the adhesions to these vessels can be a nightmare. You might end with the strokes with major vascular impetus on these patients because it's, of course, training a cyst is easy, but the consequences is high and you will be always incomplete. Especially, I'm talking decalcified lesion. I agree with Ek. When you have a calcified lesion, you have to take all the attentions not to injure the vessels surrounding. We see it even transcranially. The adhesion is tremendous when you dissect this lesion. And I think that approach you, Dr. Abuzer mentioned was described by Yashar Gil. Yashar Gil has this vast series on craniopharyngioma transcallosal approach. He was the one who put it together. But he used to say, remove it complete. And he never got the recurrence. But after 30 years, he admit for craniopharyngioma, just wait and see. You will get your recurrence in one way or other. So aggressive removal warrant good visual impact and attention to the perforator and the vessels. This is my view.
Comment, there's a beautiful paper by Falbusch, I think from 99, comparing different sizes of craniopharyngiomas, endoscopic versus open approaches. And he comes up with a good algorithm in that paper, if someone is interested in it. It's a little bit dated. It's a very, very nice paper to summarize a very large series.
That was not endoscopic, Ek. That was classical.
Most of it was open, I agree. Just the intracellular ones he took out through the nose. That's correct.
Okay, any other comments? All right. In that case, should we move forward, Pablo? We have Professor Mauricio Iaconceli from Italy on pineal tumors. Are you ready, Mauricio?
Thank you, Ramesh. Yes, I'm ready.
Okay, you can share the screen.
Yes. Thank you to you, Pablo, and Imad, all our friends from the IANA group. And can you see the presentation?
Yeah.
Okay. And I thanks for this opportunity because I think from my career when I studied the anatomy is the key. Pernesky always say, if you know the anatomy, at least you don't do damage. So that is important, the know anatomy. And Abu Zer give a great presentation that, how say, introduce my presentation on the anatomy. So I will present you some case and some approach related to that anatomy. As many times we faced many options in our approach. As you can see here, there is several options to reach the third ventricle, the posterior region of the third ventricle, and the pineal region. Everyone has some pros, cons, and rational. How can we survive in this jungle? I think that we need to reflect year by year, and we need mentoring. As far as I proceed in my career, I always reinforce my convincement that this rule that I learned by these giants are still modern. And it is nothing new, but if you follow this golden rule, I think even in the era of the artificial intelligence, endoscope, navigation, that are quite essential, useful tools. But we are a sort of artisan, we are master, and still I think that the ability, the skill of the hand play a role. And of course, the hand must be guided by the brain and the brain by the anatomy. Let's start to present some cases. This is a typical case, and we have several options. In my experience, the real option are the three options. One less the transcallosal, then occipital transtentorial, and infratentorial supracerebellar. That is my favorite. I know very well the Krauss book. By the way, Krauss is buried in Rome. And if you read with the detail, this book is really something unbelievable in terms of logical skill, decision making, and anatomy. So whenever it's possible, I select my first option is the supracerebellar infratentorial approach. Of course, we use perhaps in all cases the sitting position. The sitting position is the best, but of course, as you can see, the position for the surgeon is quite challenging and needs maybe 2 or 3 surgeons that change during the operation. In any case, we have a good master. I take this photo by some presentation in which Yasargil operated on the knees. But as you can see here, this is a perfectly cisternal way. At least without touching nothing, you reach the region of interest that is the pineal or third ventricle and brainstem. And this is an example how the position is important. You see, if we cut some bridging vein, cerebellar bridging vein, of course, at the beginning, I like to have an idea of the key point, of the anatomical key point, the relationship of the lesion with the cerebellum or with the other anatomical point, in order to plan and to try to prevent the complication. And you see, everything is attached on the rooftop. And in this case, if you cut the bridging vein, the cerebellum goes down without the necessity to retract the cerebellum and work without any manipulation and any spatulation. So the position is really the essential part of the approach. The approach is quite classical. Whenever it's possible, I try to open monolateral, just on one side. Sometimes it's possible, sometimes not. And the exploration at the beginning, just to understand all the anatomy. And then this is the classic view, the tumor, and at the end, the cavity, the tela choroidea, the third ventricle, the adhesio interthalamica, and the asportation. You see how the endoscopy can enhance our knowledge. I like the endoscopy. I use both microsurgery and endoscopy. I think there is no competition, but it gives you such a magnification that clear the detail. I present this other case just to show you how we can enhance our procedure with the fenestration of the lamina terminalis. It's like a third ventriculostomy in order to give because I had experience, even if you remove the tumor, sometimes there is a collapse of the CSF pathways with the acute hydrocephalus. So I try to offer, whenever it's possible, a double way of outflow of the CSF. In this case, after after finishing to remove the tumor, from behind, we reach by the endoscope, of course, the anterior part of the third ventricle. You see how beautiful is this is the foramen mauro, how the fornix. You see how beautiful is the anatomy with the endoscope. That is exactly the details, the anatomical details, the anterior commissure, the fornix, the lateral resection, the supramarginal resection. So, and when identified the lamina terminalis as a ventriculostomy, simple ventriculostomy, we can make an hole in the lamina, and we see in few seconds the anatomy of the anterior circulation from the posterior. So we can go from far behind to far anterior. And this is something that I think can help with no major additional risk to the patient, because this is even something that we have to consider. And the proof, the verification that we make an hole is the hair in front of the lamina terminalis, as we can see in this immediate postoperative CT scan. Of course, experience is important, and this is another case in which, coming with the previous experience, we make a peculiar approach. These are quite similar cases. In this case, we used the supracerebellar infratentorial approach, according to Krauss, because it details suggested us to select one approach to the other. Because in this case, the quadrigeminal plate is pushed downward. So from the supracerebellar approach, the lesion is just on the way without passing any eloquent structure. In this other case, were quite similar, but with the quadrigeminal plate dislocated backward, my feeling was that best was another kind of approach. And we came to the approach that I will show you in a second for the previous case by taking experience with this case of craniopharyngioma by the classical supraorbital approach. You see that for a craniopharyngioma, from the supraorbital approach, at the end, after the exploration with the endoscope, you see that from anterior, we reached the posterior region of the third ventricle and the pineal region here, just from anterior. You see the abendular commissure, the posterior commissure, the suprapineal recess, and we made a sort of ventriculostomy even in this case. But we try to modify a translaminar approach to reach the posterior part of the third ventricle by the supraorbital approach. And you see, the rationale was that whenever it's possible to follow a cisternal way. This is the projection of the pointer at the beginning of the operation. And you see how the subfrontal translaminar terminalis trans-third ventricle approach was the straightforward approach without touching any parenchymal structure, eloquent structure, up to the lesion. And this is what we did, using a mixed approach, microsurgical and endoscopic. You see the anterior commissure, anterior communicating artery that is fenestrated, the opening of the lamina terminalis, and then confirming by the navigation with the endoscope, we start some intracapsular decompression, and then because the microsurgical approach is much more faster, we continue with the microsurgery, and then the final endoscopic verification. So this is an example how we have a 360 degree of approach according to the patient, to the location of the lesion, but we can reach the brain from one side to the other. At the end, the brain is a ball, more or less. Few technical advancement, always taking into account the necessity to follow the system, the preformed way, the natural way. You see, for to approach the third ventricle, most of the time, I already used the transcortical approach, but the transcortical approach, you see, damage of course, the brain parenchyma. So we, whenever it's possible, we try to use for example, the transcallosal approach that is straightforward, and we can reach the third ventricle quite easily. Sometime through the pure endoscopic approach, we can even reach the posterior third ventricle region by a sort of endoscopic transchoroidal approach. This is a case in which we displace the choroid plexus and pass through the choroid plexus in order to reach the posterior part of the third ventricle. In this case, there must be small lesion, and the problem is the instrument. We have not so many, so we can use the balloon as a dissector, or some the coagulator as a dissector. So we have to try to adapt ourselves. Moving forward, we modify a little bit the approach just to navigate the endoscope to have a pure endoscopic approach transcallosal to follow a natural way. You see, with the endoscope, we reach the third ventricle just with the few millimeter callosotomy that I perform under the neuronavigation with the endoscope itself, just moving a little bit forward in every step. You see the footprint of the endoscope, and millimeter after millimeter, I reach the third ventricle, and then work as usual as the transcortical approach, but as a pure transcallosal approach. Actually, is not really pure, because at the beginning I make a small craniotomy and some coagulation in the surface is made by the microsurgery. But most of the procedure is done by a pure endoscopic transcallosal approach, and that I found quite parenchyma safer, because in this case you just see the tract, but in the midline with a really few millimeter callosotomy, but you see in the parenchyma was completely preserved. Sometimes, hopefully, and for fortune, the lesion does the job. In this great giant cavernous angioma, in this case, is not actually a real approach to the posterior third ventricle lesion, pineal or brainstem. This is a simple approach that you can use, any approach. The lesion do the role. So in conclusion, the golden rule is seem pleonastic, but is do not touch the brain. And I find in my fellow, in my resident, the tendency to use anything that is new, but without not reflecting about the real potentialities of the new instrument, the new technique that we have to consider. I really don't like the competition between endoscopy and open microsurgical. We can use both independently. And the anatomy, the knowledge of the anatomy is very important and give you the way. And as you have seen in some cases, if you know the potentialities, if you have a multidisciplinarity, sometimes discussing it is possible to raise the bar together and to find some unexplored indication. And another reflection that we say, now we talk about the maximal safe resection. What does it mean, maximal safe resection? Maximal safe resection is the Hippocrates sentences that the primum non nocere is always on our soul. And in conclusion, as far as I studied the old book and the history of medicine, I found that most of the time everyone said the same that we try to discover now. This is a sentence I like from Emil Cocker 1 century ago. That is the exact philosophy of the minimal invasive surgery. Approach should be as large as necessary and as small as possible. So sometimes we have to reflect about the history. I thank you for your attention. Thank you.
Thank you, Mauricio. Brilliant talk. I have some comments, but I'll leave it with Imad, and Tibak also, and Giovanni. So start with Imad.
Yes, I think most important for the young generation watching this presentation to understand anatomy is essential. And like MRV is an important examination for posterior fossa tumor and pineal region. And sitting position for supra-infra is essential. If you do it in prone position, you lose all the value of the gravity to reduce the minimal retraction. The other things to be studied is what they call the tentorial angle. The sharper the angle, it makes it difficult to go this approach sometimes. And that's where the eccentric approach can help in some cases where the angle is softer. And this is where the hybrid use of endoscopy is an add-on. Now, lesions that are big, it depends all on the pathology. Pineal region, pineal tumors, I agree with you, this is the best approach invented. But a giant tumor with extension anteriorly and inferiorly and laterally, you mentioned it, Mauricio, but you have not talked about it, is the occipital transtentorial. Occipital transtentorial was initiated by Pope and then modified by Osman. And I use it for the eccentric lesion and large lesion because it, especially in meningioma, because you can devascularize from the ficrotentorial area, and even you can reach the cinnary vessel at the tentorial edge for these approaches. So it has to be in the pocket or listing of the approaches as well. Thanks.
No, I agree with you, Imad, and I learned this approach, unfortunately, many years ago by Claude Laprat in Lione, and there was a fun about the occipital transtentorial. It's a good approach. I agree with you. If the tumor is exactly most supratentorial, and especially on meningioma that is attached to the tentorium, or with the tentorium is steep, you are right.
Okay, thank you.
Yeah.
No, I really enjoyed your talk, Professor Maurizio. Actually, Dr. Imad has already asked my question about the position. At our center, we just use two approaches primarily. One is the occipital transtentorial, depending upon the MRI. And otherwise, sitting position is the one which we use the most commonly in our center. What is your take on that?
Sorry, Deepak, I didn't understand correctly the question.
So what is your recommendation about the sitting position for pineal tumors in your center?
Of course, the sitting, in my opinion, to reach if the tentorium is not steep, the sitting position is the best because of the gravity. So whenever it's possible for posterior brainstem tumor, for posterior third ventricle region, for pineal region, I prefer the sitting position. I don't use the sitting position, for example, even if some of my friend is a fan of the sitting position for the vestibular schwannomas. I think that the vestibular schwannomas, I don't think you, because I have some disgrace with the vein and with the supratentorial acute subdural hematoma. So, but for pineal region, in my opinion, if you use the infratentorial supracerebellar approach, is essential. Sometimes, if the tumor is really big, with a big supratentorial extension in meningioma, I use the latter, like a sort of park bench, 3/4 prone approach, the occipital transtentorial approach.
Thanks. Giovanni?
That's quite rarely.
Yeah, Giovanni, you want to? You muted, can you unmute?
Yes, the Imad was most of my question. I have one suggestion for young people and one question for Maurizio. The suggestion is that remember that when you put somebody in sitting position, he has to be no curarized. Otherwise, you get in trouble mainly if you try to get the position due to the angle of the tentorium. That is very important. And the question is a wonderful presentation. I was impressed by your approach to true lamina terminalis from the basal, frontal basal way. Any problem, any hypothalamic problem afterwards?
No, because if it's a real, of course, is quite uncomfortable. And I use this approach when the frontal sinus is quite small, because if you stay as much as possible median, the translaminar approach is straightforward. Otherwise, there is a little bit traction, as you mentioned, on the hypothalamus, on the optic nerve. But really, if there are the condition, is really a straightforward way. And I found of great help the endoscope. With the endoscope, even if you have a small hole, if you have not everything not exposed, you of course for not so big lesion and not so adherent, with the endoscope it's possible to work. On the other hand, we work for giant craniopharyngioma or pituitary adenoma through the nose. So with a little bit of adaptation, I think it,
2 hands or 4 hands endoscope approach?
No, we are old-fashioned because I don't use the older, but we are two surgeons that we change, and it's a sort of I would say, even when you play the double in tennis, everyone must be diciamo, a component of the other. So sometimes I or my partner use the endoscope just even to make a little bit of traction. He used maybe the sacra, I use the curette. So we really work forehand. I would say at least 3 forehand sometimes, but 3 hand most of the times.
Yeah. Vladimir?
There was an excellent lecture, especially I enjoyed the conclusions. I will make few remarks for supra-infra. The most important factor to decide which approach is the position of the vein of Galen. If the vein of Galen is above the lesion, then it's supra-infra. If it's below, then it's falcotentorial. And for supra-infra, over the many years and many surgeries, I do not use bilateral approach at all. You can get everything from single lateral side because it's far, so you do not need that much of an angle. The advantage is that the tentorium is not as steep, it's closer trajectory, and you preserve all the vermian veins, which is important. You never had them. Then opening the dura, I start with lumbar drain, 30 cc. You open the dura just parallel to the transverse sinus, and you immediately see the tentorial hiatus because it's gravity which really helps. And if you open the dura too low, then the cerebral tonsils, cerebral hemisphere tend to prolapse. So really just parallel to the transverse sinus. And the last thing is that I found that exoscope is much more ergonomic because it's flexible. You can have the head of the exoscope wherever you need to. You can have your hands flexed, not as with microscope where you really need the long hands to read the pineal region. So it's really beautiful approach, and especially with this exoscope you get everywhere easily and shortly.
Yeah.
But nice, beautiful lecture.
More ergonomic position. You are right. But sometimes even with the exoscope, I use the endoscope because in the depth, the endoscope gives me the.
Sure, by all means.
Even
by all
working
means.
with the same screen. Sometimes because Storz have the exoscope and the endoscope, so you can switch from the exoscope and the endoscope in the same session.
By all means. Yeah.
Okay, excellent. Thank you. Thanks very much. And we've been joined by Miguel. Hi, Miguel. And Davida and Henry as well.
Well.
Good. Hi, Davida. And Pablo, we shall be... Hi, Henry.
Hi. Hello. Sorry, I'm a little bit late.
Welcome, everyone. We have one question, Ramesh, in the chat box. What's your air embolism rate? And what do you do to avoid this problem? Do you use lumbar drainage routinely postoperatively?
Lumbar drainage quite rarely, but I'm not afraid to say when you got a compress and no one used the lumbar drain, and in the clinical practice everyone use the lumbar drain. So when I make the transclavial approach, I put the lumbar drain. When I make an extended endoscopic approach, I put the lumbar drain. But specific in the pineal regional approach, in the infradental supracerebral, I think it's no need the lumbar drainage. To avoid the higher embolism, that is a concern. As usual, the transesophageal Doppler, the use of position, the positive position. But this is something that we try to avoid all the sucking on the vein, but this is actually a main concern of the anesthesiologist. The anesthesiologist must be skilled enough to prevent and put all the tube, all the catheter inside. And so far, it's quite rare. I have not the real data, but maybe 1, 2 air embolism, and no one was fatal. Because you stop, because the anesthesiologist if he's prompt, stop you and you change position, or they make a positive pressure. So it is a concern, but with a good preparation, good planning, with a skill enough anesthesiologist, maybe is not a big concern. Maybe.
One thing, Pablo, I'd like to add some comment on this one. May I?
So,
yeah.
Yeah, important for the young generation starting sitting position. We are talking not a pure sitting nowadays. We all move to semi-sitting position. It has to be understandable. So the chance of massive collection pneumocephaly is much less. The other thing, lumbar drain, as my colleague Vladimir said, this is the best invention. I agree 100%. But the way you do it, as he mentioned, he drained a little bit to relax the cerebellum and have the access, but you don't keep it open. Of course, you keep it open and drain off the PSF and you get the pneumo. So the way you titrate the drainage and you close it as needed. Once you drain the 10 cc or 15, it'll be adequate for the access. This is where you need it, and then you close it. If there is any cerebellar swelling, then a different story. But in general, that's what we do, and then we take it out at the end. Thank you.
Can I add something to the sitting position? We check all the patients prior to surgery if they do not have foramen ovale apertum. That's important. Then we use transesophageal echo. And then during the approach, all the possible openings are very carefully occluded. Veins, bone, everything. And I cannot remember when we have seen it.
Comment. There's a beautiful paper that Markus Tatajiba published last fall, 1,000 posterior fossa cases in the sitting position and no increased rate of clinically significant air embolus. It's in JNS. It's definitely worthwhile reading for different pathologies. So whoever is interested in, please pull up this paper.
Yeah, great paper.
thank you.
So, Deepak, you want to say something, or we should move on?
Yeah,
You're muted.
Just one small comment. In the sitting position, pre-operative hydration of the patient is extremely important, because many times if the patient is not adequately hydrated and you make the patient sit up, there is hypotension, and many of these patients, they actually wake up paraplegic. So the anesthetist need to be conveyed that the hydration has to be, patient has to be given some fluids prior to positioning in the sitting position.
Okay, let's move on, Pablo.
Ramesh?
Yeah, you want to move on? I think we can, next talk.
Let's move to Vladimir.
Yeah.
So Vladimir Venesh, no need for presentation, introduction. He's going to talk about ependymomas of the fourth ventricle.
All right. Is the screen all right?
Yes.
Yeah, okay. I'm going to talk on my favorite topic, which are ependymomas of the fourth ventricle. And I stress that it's adults. They have nothing to disclose. Those are really rare tumors, the ependymomas of the fourth ventricle. They compose less than 1% of all gliomas. And vast majority of them are grade 2. It means low grade. There is a general agreement within our community that ependymoma is purely surgical disease. No radiation, no cytostatics, etc. You can use radiosurgery, but still it's questionable. And what I'm going to talk about are only the tumors with the origin on the floor of the fourth ventricle. If it's origin or part growing subependymally, it may be discussed, but I call it origin. The anatomy is easy and well known from Roton and many other studies, especially produced by IANA. And this is where the tumor grow. I have never seen the tumor which would be growing from upper portion of the fourth ventricle, always below the level of foramen narusque on one side, most frequently on the right side. I don't know why. This is the position how we do it. The patient is prone. I'm coming from the head, and it's either microscope or exoscope. And as I said, with pineal region, exoscope is much more flexible. You get better angles. You much better see into the fourth ventricle, into the upper part of the fourth ventricle. So step by step, midline suboccipital craniotomy, if needed, laminectomy or laminotomy C1-2, depending on tumor extension. If the tumor extends into the CP angle, then enlarge the craniotomy along the base of the posterior fossa and along the sigmoid sinus, depends on the tumor. Starting with puncture, dura, and arachnoidea at C1 level, just to release the CSF. You will see on video how it really helps. Y-shaped dura opening, as usual, always, but I use hemoclips to control the venous sinuses. The hemoclips are then removed. Cisterna magna arachnoid dissection, and if needed, into the CP angle. Then I always start with lower tumor aspect, which is dissected to the floor of the fourth ventricle as far as the origin of the tumor is seen, then the lateral aspects along the tela and down to the floor of the fourth. Last is the superior aspect, and then the tumor is debulked. Then, as the last, when the tumor is really mostly out, the tumor origin is addressed, and then, of course, wound closure and, of course, monitoring. So here is the first case, quite typical. You see the arachnoid dissection. I like to use mini clips to hold the arachnoid open, but I never suture it, of course. And this was a nice case because the tumor protruded out of the foramen majorly, so it was easy to get all the orientation. You see the tumor, you see the picas, which are dissected free. The tonsils are released only in the medial part, not as in a pure Terrell approach, only as much as needed. And here's already the floor of the fourth ventricle, the calamus area, where the floor is clean, but then the tumor origin comes. So we turn laterally, first on the one side along the tela, going upwards, and then on the other side, dissecting all the vessels which do not belong to the tumor, and only the smallest vessels do go into the tumor. Any larger vessel belongs to the brain. You see going along pica. Now we are above the tumor. It's always the nice part of surgery because the floor of the fourth ventricle is perfectly free here, and you have all the space you need. And then dissecting the tumor on the opposite side along the tela, and then the main bulk of the tumor is out. Usually the tumor is divided into two parts. One part is the larger one, which is already dissected and free, and the one which is growing subependymally is left behind until the very end, when everything is nicely seen. The floor is completely clean, and only the little tiny part which is growing subependymally is then addressed. Scusa liberally used as much as needed. and there is not much bleeding usually. If there is, it's better to leave it behind. It doesn't matter from the tumor. And now we shall see the tumor which is subependymal. You see the remnants of the tumor on the right side in the lower quarter of the fourth ventricle. So slowly, piece by piece, this last remains of the tumor are addressed. This is the beginning of another surgery. You see that the tumor goes into the CP angle in this case. This is the CSF release, then opening the dura between the hemoclips, prevents any bleeding from the sinuses, which may be dangerous. And then again dissecting the calamus scriptorius, finding the lower aspect of the tumor. You see how nicely and clearly it's seen. And again, we have the floor of the fourth ventricle free already here, both picas dissecting free. And here we have tela, and we go along it, opening the CP angle because that's the side where the tumor seems to be protruding, maybe even into the CP angle. So just to be prepared. In this case, it was not needed to approach the tumor through this. And again, on the sides of the tumor, going as far down as the floor of the fourth ventricle, sharp blood dissection. And only when both sides are dissected free, this is the left side, you see the vessel which does belong to the brain, so it's spared and pushed laterally, and only the tela is opened, going higher and higher along the tumor. Here's the clean floor of the fourth ventricle, but the tumor will still be growing very close to this area, but higher up the floor is nice and clean. And this is the upper part. And again, the tumor will be divided in two parts, the major part, which will be resected, and the lesser part, which is like a tumor origin within the floor. The tumor is rather nicely dissected out of the foramen and Luschke, but whenever the tumor goes more to the cerebellum, then it becomes more invasive. You are not really in a, the plane of dissection is not really that clean. And now there is the remnant where the tumor is truly subependymal, monitoring all the time, and this is the subependymal growth. The last case of the before last, you see on MR how deep into the bones the tumor is embedded, how much subependymally it grows, floor of the fourth ventricle, very clean, very nice anatomy. And this is the major part on your left, on your right, and on your left is the subependymal part of the tumor, which actually is then resected in the same way as you resect the spinal cord ependymoma. Just the dissection from inside out without any movements in the direction of the neural tissue. You see the remnant, which is subependymal, and again with the monitoring. And you need to monitor very closely now because we are somewhere where the 12th nerve has its nucleus, and then the tumor is resected. No coagulation, no nothing, just patient hemostasis with Surgicel or gel foam or whatever. And you see that there definitely must be some bleeding. So there is the bleeding because this was completely subependymal, this part of the tumor. And it's never chased and never coagulated. This is after MR, and the last case, this was one really the most difficult one, going up to the aqueduct down to the C3, and you see here on axial that the tumor actually envelops the brainstem, envelops both picas and vertebral arteries. So see if it looks like, again, starting from below, from the spinal canal, piece by piece, this tumor was very globular, and it had many tanks going into the blind alleys. I cannot speed it up, but the part in the spinal canal was not really that difficult. The difficulties came when we arrived higher up to the vessels, because they really were enveloped by the tumor, and definitely the orientation there was not that easy. So piece by piece, this is the denticulate ligament of C1. And now we are already in the main bulk of the tumor within the fourth ventricle. And by careful dissection, you find the arteries, you release the picas. I release the vertebral arteries and the nerves, especially on the left side. It was very, very invasive tumor. You see, here we are above the tumor. This is coming out of the fourth ventricle, and you see I call this passive mode of CUSA, that the tumor comes to you and you just decrease the size by the CUSA. You see how nicely the upper portion of the tumor is delivering itself. And we now will get finally to the floor of the fourth ventricle, which was the first time I saw it throughout the surgery. Here already one of the picas is dissected free from the tumor. And we now shall go to the CP angle on the left, then to the right, dissecting the tumor and taking all the parts which were in the floor, embedded in the floor of the fourth ventricle, preserving all the nerves and all the structures. Now we are coming to CC region. These are the picas over here already liberated from the tumor. Now we're going to see the brainstem is over here, still covered by the remnants of the tumor. The left pica, the floor of the fourth ventricle over here, and you see the tumor which really grows subependymal in this region. Another vessel over here. This is the 11th nerve. And going up to the 11th nerve, we got to the foramen jugulare, seeing 9 and 10th. And the tumor was really enveloping the nerve. It was, the nerve was encircled. The 12th, the same, the 12th was dissected 3 a little later. Now we again are dissecting the tumor from the vessels, and from the floor of the fourth ventricle, you see the pica and you see the tumor in the floor of the fourth ventricle. And in the left CP angle, the tumor reached as high up as 7th, 8th. They were at the top of the tumor, still stretched a little superiorly. The right side was a little easier. You see now the 11th nerve is running through the tumor. There is the tumor going anteriorly between the vessels and the neural structures. This was definitely the tumor which took me quite long to resect. It was piece by piece. You see that there's one of the perforators, the floor of the fourth ventricle, and the tumor remnants almost everywhere. And this is already the CP angle, which is free. High up there is 7th, 8th. Here is the foramen jugulare. Here would be the 12th nerve. And this is after the surgery. You see the radical resection, and the patient is now, I guess, 4 years after the surgery. So this is it. This is the tumor origin in the lower part of the fourth ventricle, which can really be expected. You can bet on that the tumor will be subependymal in the lower half of the fourth ventricle, allowing you to dissect the tumor easily from the upper part of the ventricle. Over the 20 years, we have had 31 cases, 50 years old. 2 tumors were grade 3. We had 4 relapsing tumors. One relapsing surgery was after myself when I left a piece behind. 3 came from elsewhere. One patient died. That was the typical patient who was decompensated, 80 years old, too much, too late. I produced 2 new permanent deficits in swallowing, but fortunately, the quality of life is not that much affected. 3 new temporary deficits, which improved. In 84 cases, there was radical resection. And what's important, as of now, I didn't see any recurrence over the 20 years period. There were 3 remnants sent to radiosurgery, and then they are stable, and 2 remnants are only observed, and we do not see any growth. So in military terms, which applies to all the tumors, not only the ependymomas of the fourth ventricle, surround the enemy, cut the supply lines, decrease the size of an enemy, clean the last pockets, and then reconstruct the territory. It was best seen during the World War II in Stalingrad with Paulus army, which was surrounded, cut off the supply lines, decreased, and then gave up. So in general, I would conclude that the fourth ventricle ependymoma in an adult is a curable disease, because you really do not see relapses. And radical resection is the aim of the treatment. There is no place for partial resections, no place for some half measures. Always the aim of the treatment should be the radical resection. Thank you very much.
Thanks, Vladimir.
Well,
Pablo, sorry, can I ask something, Vladimir? When you see the tumor, how far you chase into the brainstem? Sometimes you go after when have a nubbing into the floor of the fourth ventricle, or you try to stay above the plane of the fourth ventricle floor?
No, I chase it. I chase it, but the decision then depends on the monitoring. Should I see that I'm too close to, let's say, most frequently it's 12th nerve nucleus. If I am directly on that, I stop. But it's very seldom, and you almost always can luxate the part of the tumor which is within the pons or oblongata. It's pons. So it's really with some patients, you get the tumor which is below the floor out.
Deepak?
Yeah, Professor Vladimir, excellent talk. Just 2 questions. One, in very young children, have you ever attempted opening the dura in a U-shaped fashion to protect the circular sinus? And my second question is, I saw that you took out the tumor in totality in 2 parts. How often do you use CUSA in your practice for ependymomas?
I cannot give you opinion on U-shaped on pediatrics, because we do not have the pediatric service. You must ask my son. And what was the second question? How
often do you use CUSA for ependymomas?
Always. Once I get the superior portion, once I'm oriented with the superior portion of the tumor, I use CUSA deliberately, because that's you saw how the tumor is coming towards you. So CUSA is extremely helpful.
Thank you.
Can I ask something, Vlad?
Yeah.
Do you you explained that most of the cases you have analyzed, you somehow can understand or identify in the pre-op MRI where the tumor is in more close contact or is inside subependymal on the fourth ventricle floor. So you carefully, I understand, you carefully analyze your images. And my question is, how and when do you deal with that last part? Do you leave it for the end, or you attack it from the beginning, or you map around? How do you think about that?
And slowly approaching with a continuous resection to the point where it's subependymally. You know it in advance, because once you come from below, you lift the tumor and you see where the ependyma is attacked by that. And it really does not matter whether it's like on the surface of ependyma, which is only destroyed ependyma, or if it goes below the surface. I'm unable to recognize it on pre-op MR. It's I always just I know in advance where it shall be. I leave it until the very end. It's the last remnant of the resection, and it does not really matter whether it's on the surface with only destroyed ependyma or whether it goes below the ependyma. These are, of course, more difficult, but the last remnant is left for the end of resection. Because then you have enough space, you see it, and you know where it will be. Because I'm as yet to see another part of the floor of the fourth ventricle which will be attacked. It's always the lower quarter and most frequently on the right side, which doesn't have logic.
Thank you. So, if we are ready to jump on the second session, I would like to ask, I thank you, Ramesh, for your help.
Thanks, Pablo.
And
Thanks,
all the
everyone.
speakers. And I'd like to introduce Imad, Kanan, and Ek Kasper to introduce our next speaker.
Oh, we're missing.
Imad, do you want to do the
Henry?
introduction?
Well, I'm just wondering, Henry is not giving his presentation.
Henry is at the end. We changed the sequence.
Oh, okay, I didn't know that. Okay,
Yeah.
go ahead.
Come later.
All right.
Okay.
So
Best at the end, you know.
our next speaker is our good friend Miguel Ares, a professor in Malaga, Spain, and a long-term member of the anatomy team and IANA. He's going to give us a presentation about Pontine brainstem tumors, and I'm looking forward to an exciting talk. Miguel, good to see you again.
Thank you very much. Thank you very much, Pablo, and the other colleagues for the kind invitation to participate in this wonderful IANA webinar. My topic is about surgical approaches to Pontine brainstem tumors. I think that we all know this very functional area with many sensitive nuclei and long pathway and offering from the anatomical point of view two surfaces for surgical approaches. I think that the presentation of Vladimir was a wonderful introduction in regard to the fourth ventricle route for brainstem tumors. And we have to mention that fourth ventricle is suitable for medullary tumor, tumor of cerebellar peduncles, and of course for Pontine tumors. During my talk, we will mention something regarding alternative routes to the fourth ventricle as most suitable routes trying to remove lesion inside the Pontine region. Going through the fourth ventricle, excellent videos and excellent presentation from Vladimir Benes in regard to what we can consider the intertonsillar approach, basically for ventricle and brainstem medullary tumors, transvermian approach through uvula, pyramid, tuber, and folium, and telovelar approach through foramen of Magendie, telachoroidea, and inferior medullary velum. We see this picture with Professor Matsushima, who very much published in regard to this route, and we can summarize with the aid of this wonderful slide from Pablo and his group regarding these two approaches, the transvermian and telovelar approach. We have to mention that at the beginning, in my personal practice, I did many cases through the transvermian approach, later on through telovelar approach. But we have to also mention that according to the literature, we can see this 2024 series meta-analysis showing that actually postoperative complications are almost the same with the telovelar and the transvermian approach. We also have to mention what is more and more considered for brainstem surgery, that is the concept of safe entry zone. That is to say, which part of the anatomy of the brainstem can be used to get inside and remove the lesion without adding morbidity. When dealing with the posterior Pontine region, we have to mention the foreventricle, of course, and by means of occipital craniotomy, safe entry zone, we have the median sulcus and supra and infra facial triangle pericollicular area, very much described as a route trying to avoid the nuclei of the 7th and 6th cranial nerves. This is a patient with progressive diplopia and steadiness and this progressively growing lesion at the foreventricle. And I think this is a very straightforward approach. It is an old case to me, did through transvermian approach, big lesions. So first of all, trying to make the bulking, and then the key issue, trying to avoid postoperative deficit, is the plane, the interface between the tumor and the brainstem. We can see how carefully I like this blade, this instrument, and you have to try to be sure that you have removed everything. In that case, we will see almost complete resection, but we can see how easily you can leave behind some big part of the tumor that may just lead to a recurrency of the lesion. In this case, we have the impression that we have completely removed the tumor. As you can see here, this is the postoperative MRI, but 14 years later, we saw this recurrency, big lesion again, and you can see this video, the lesion going back to the foreventricle, and actually some difficulty to remove, some difficulty to remove the lesion because there was no good plane. In any way, we managed to remove the lesion. As you can see here, some clean tumoral bed after the resection of this recurrency. This is a typical case, typical indication for surgery, 20 years old patient, hemiparesis, left sixth nerve palsy. You can see this lesion that was initially managed conservatively in another institution, but 2 months later, this rebleeding at the foreventricle, and again, using the foreventricle as route for removal. We have to mention that to the classical procedure for intraoperative monitoring, we have to add the mapping of the foreventricle as a way of trying to diminish morbidity. In that case, not very easy to find midline, as you can see here. Finally, we managed to completely remove the lesion. We like to see after removal this clean plane after some, let's say, easy removal. And this is postoperative MRI, and the patient with some slight impairment of his condition that is not very seldom seen, but after that, little by little, the patient usually have a very good recovery. So I think this is, in spite of the risk of that operation, is a very satisfactory operation. This is another patient with 2 previous episodes of hemiparesis and facial deficit. You can see another typical cavernoma. Main indication in adults is of course cavernoma, and this is after the operation. MRI seems to be nice, but we found a very gliotic, very difficult plane, and unfortunately, we had this postoperative deficit with conjugate gaze and right hemiparesis due to this problem. Another young patient with facial palsy, diplopia, first episode, some edema. We deemed the lesion to be very accessible and we did the operation with a pretty satisfactory result. And also, I think this approach to the foreventricle is useful for lesion in the limit between the Pontine and the upper medullary region, as in this case, with initial bleeding and rebleeding with tetraplegia and respiratory arrest. The patient was operated on in an emergency basis with good result. We can see after removal the clean plane underneath, after complete removal of the lesion and postoperative MRI. So we mentioned alternative route to the foreventricle. Foreventricle is okay, but it's a risky area with potential increase of preoperative deficit. And for certain cases, you have to consider a different route. This is a patient with several episodes of bleeding and intermittent neurological deficit. If we see this MRI, we can be tempted to go through the foreventricle, but we have to see very carefully the full spectrum of images, and actually the lesion is in between the Pontine and the medullary region. And those cases can be very easily approached through a simple retrosigmoid approach. We are working between 7 and 8. This is 9 and 10. The exposure of the lesion and removal, again, unfortunately, with this not very clean plane that made the removal difficult. The patient had been waiting too long due to the waiting list, waiting too long for the operation, and MRI is fine, but the patient had remarkable increase of the postoperative deficit. It's very important to mention when talking about brainstem cavernoma surgery about the timing for surgery after bleeding. Acute stage, subacute, delay surgery. Delay surgery is not appropriate. It is deemed to be appropriate something no more than 6-8 weeks after the initial bleeding. But sometimes you have to do surgery in acute stage. This is another patient, young patient, with a sudden episode of tetraparesis and comatose situation that we had to operate in emergency basis. The lesion was a cavernoma, but approach through the foreventricle, but bleeding like a real AVM. And as a matter of fact, you can see this postoperative MRI, this small remaining of the tumor that is under follow-up. The patient was operated on more than 30 years ago, but this small rest is just something making you being worried about a possible recurrency or rebleeding in the future. Last part would be about the ventral lesion at the Pontine brainstem. Mention that anterior aspect, we have to mention two safe entry zones. One is the peritrigeminal area, the picture here, and also the exit in between, the area in between the exit of the 5th and 7th nerve. We have a very good anatomical explanation, thanks again to the wonderful preparation of Pablo Gonzalez and his team. And we can see how the corticospinal tract at the anterolateral aspect of the Pontine region has this loosened distribution, and at the same time leaving that part with less functional potential damage that is right behind and right beside the fifth entry, the fifth nerve, the trigeminal nerve. And how to get to this peritrigeminal and between the exit of the 5th and 7th area. We can do a presigmoid, transpetrous, or retrosigmoid approach. This is a patient operated on many years ago. We saw the lesion here, 5th nerve, and we understood that this presigmoid approach could be some very straightforward, direct line approach. And we can see we are at the left side, after petrosectomy, opening of the dura. You can see tentorium, sectioning tentorium, and we can actually directly see the dandy vein complex and also the fifth nerve, a small opening beside the fifth nerve, peritrigeminal area, and just getting inside brainstem and removing the lesion, very easy removal of the tumor. Let's say 12-15 minutes to remove the cavernoma and 4 or 5 hours just to get there. But we have, this is something good because you can remove the lesion, see the resection, reconstruction with fat graft as customarily done after petrosectomy. But we have learned that that cases at the anterolateral Pontine region can be very easily approached through a simple retrosigmoid approach. This is right side, this is the fifth nerve, this is 7 and 8, and the way you can make some small opening between 7 and 8 and fifth nerve and removal of the cavernoma, as you can see here. Not at all a time-consuming operation with a pretty good satisfactory result. And no matter how big or complex the lesion at the anterolateral Pontine region is, by means of a simple retrosigmoid approach, you can remove the tumor. This is a patient with cavernomatosis, as you can see, and this long standing lesion with cavernomatous tumor in different stages. I don't know what is going on. That music. Okay, so, okay, this is the tumor, and this is the exposure through CP angle retrosigmoid approach and pretty satisfactory MRI. And this is the patient during the immediate postoperative admittance, and the patient 6 months after at the gym with good functional situation after removal of such a complex tumors, as I mentioned, through simple retrosigmoid approach. You can also use for cerebellar peduncle several routes. In that case, a young patient with dizziness, ataxia, second episode of bleeding, we used the fourth ventricle. This lady was operated on long ago. I will skip the video. With good immediate postoperative situation, a slight increase of the deficit of the patient, and good postoperative MRI, but we have again to consider different possibilities like retrosigmoid, transcerebellomedullaris approach, and also, of course, you can consider the fourth ventricle approach. But my comment is in regard to how much we try to avoid fourth ventricle because of difficulty and risk of increasing morbidity. My last comment is that, of course, the decision of the surgical approach is based on anatomy. We are in one of the webinars of the International Academy of Neuroanatomy. Fourth ventricle is one of the surgical routes, and we have to consider transvermial and the telovelar approach. Telovelar approach now is our favorite because we don't have to split and to section any anatomical structure, and on top of that you have more ease to get to the upper and more rostral aspect of the fourth ventricle. We have to consider, when dealing with a Pontine tumor alternative to the fourth ventricle, that we have seen that may be useful and completely extra cerebral approaches, and of course always taking into account the concept of safe entry zone. Thank you very much for the invitation. Thank you very much for giving me the possibility to be among you that are a wonderful group of friends and yourself. Thank you.
Thank you, Miguel. Excellent presentation. Does anyone from our panel here have any questions for Miguel? Vladimir.
Miguel, I have learned the hard way that to approach the cavernoma of the Pontine cavernoma through the floor of the fourth ventricle is something which should be avoided. So unless the cavernoma really protrudes into the fourth ventricle, I always look for some lateral route. What's your impression on that?
Yeah, well, it depends. There are cases and cases. The first case I show, there was a cavernoma, not only inside, the cavernoma was at the posterior part of the Pontine region, and not only insinuated in the foreventricle, but it was like, let's say, ependymoma, half of the tumor inside the foreventricle, half of the tumor inside the brainstem. Of course, foreventricle is the appropriate route. And sometimes, as I have shown several examples, sometimes you have to do that because the tumor is not close, it's not abutting the surface of the brainstem, so you feel compelled, you feel obliged to go through the foreventricle, but the foreventricle, sorry. But in case of that, I think we have to go to alternative route to the foreventricle. Sometimes you may tempt. We have several examples of tumor in between Pontine region and medullary region. Looking at the axial view, you can see the tumor beside the foreventricle, the floor of the foreventricle. This is true. But if you look at the MRI, the coronal view is very striking and is leading you to the CP angle with easy removal without, let's say, touching the nervous system.
Historically, Bricolot from Italy, God bless his soul, he was the one who described transventricular fourth ventricular floor. And his recommendation, he was mapping the facial hene by stimulators and avoid the midline. These are the two recommendations from his time. I don't know whether you are still considering this or not anymore. You mentioned that you go more.
Well, thank you very much, Professor Canan. Well, first of all, I think that the modern neurophysiology has to recognize and has to credit to Albino Bricolò surgery of the brainstem in general, but particularly the identification of the nuclei at the foreventricle and the concept of mapping of the foreventricle. That was not, let's say, devised by neurophysiologists or neurologists, but by a neurosurgeon, Professor Bricolò. I 100% concur, but well, actually, we use midline if you have a symmetrical tumor growing over there, but this is not, if the tumor is big, probably you have this symmetrical, let's say, anatomical appearance. But very frequently, you have the tumor lateralized, and you have to try to go as a there are several principles to my mind in brainstem surgery, cavernoma surgery, basically. One of them, just trying to go to the area where the lesion is abutting the surface of the foreventricle or the outer, let's say, ventral or ventrolateral brainstem surface. The other one is just following the safe entry zone, several sulci that maybe even split, very important at the posterolateral mesencephalon, lateral mesencephalic sulcus, and so on. And there is another rule, the rule of the 2 points, according to which you have to put 1 point in the center of the lesion, another point in the area of the closest surface, and then starting a line. But this is not always working well because if you do that, some of the tumor that can be now very easily approached through the CP angle should be approached through the clivus. That is not advisable.
Thank
you. This is my understanding.
Yeah, I agree with Vlad. I also have the experience that when you go through the floor of this fourth ventricle, you have a higher risk to have deficits. Even if you map with you make an infra or a supracollicular approach, usually it is limited. So I do it really only when it's very, very small and when it's really close to the surface.
Right.
Even when the way is long, I come from for Pontine and midbrain lesion always lateral. And for the Pontine lesions, I make retrosic approach, and then I open the pontomedullary fissure, and then I go through the cerebellar peduncle. The middle cerebellar peduncle. It's a long way, but with navigation, you come in, and with this, I had the best experience.
Good. I have to mention that I have to go through a very long way. I try not to operate that patient. I like to operate only easy cases.
Yeah, but when it's symptomatic and large, then I think
Yeah, of course. I'm joking.
Thank you.
Matt mentioned Albino Bricolo, who definitely was very founder of brainstem surgery. But Miguel, you have had a Spaniard who was excellent. I know that it's just the opposite side of Spain, and it used to be Fabian Izamat in Barcelona, who did lots of brainstem surgeries.
Fabian Izamat, yes.
Professor Fabian Izamat in Barcelona, who used to work in Belviche Hospital, and has particularly one, let's say, pioneer publication on brainstem cavernoma, published in Technical Advances in Neurosurgery, the publication of the official publication of the European Society. Yes, actually, yes. Thank you for this remark to some Spaniards.
Thank you. Very fruitful discussion. Imad, if you agree, can we move on to the next presentation? You introduce.
Yeah, go ahead.
Thank you very much.
Yeah. You want to go ahead, or should I? Whatever.
Please, you.
Go ahead. Okay. So in the same context now, I'm just wondering with the use of word staying calm while handling a stormy brainstem glioma, it will be given by Deepak Gupta with his experience. Deepak?
Thank you for this opportunity. Well, I think we had quite some discussions about complex surgeries in the posterior fossa pineal tumor. Why I selected this topic was because most of the brainstem gliomas, they're not very vascular tumors. However, they can inflict significant amount of deficit not only on the patient but also on the surgeon's self-esteem if something goes wrong. Well, I think the whole persona of a neurosurgeon is somebody who can make very quick decisions and cope up with anything. This is what people understand. But things do go wrong, and we all know about it. And when things go wrong, then everything descends into chaos. I think we all understand that operating room is a very complex, high pressure, and a very potentially hazardous environment for all the people who are inside the operation theater, which includes the neurosurgeons. These are the three basic common scenarios of brainstem tumors which we come across in our practice. On the left, you see the tactile gliomas, wherein we don't need to do anything most of the time, except for ETVs in some cases. In the middle part, you come across dorsally exophytic and cervicomedullary tumors, where the neurosurgeon's role is of utmost importance. And these are the tumors which we are routinely operating. And then comes the DIPG, which is known as the diffuse midline gliomas. They are usually considered to be nihilistic tumors and non-operable tumors. I would say that brainstem has got the most complex and the dense, eloquent anatomy of the CNS because of the structures described in the brainstem. In fact, there's a beautiful publication which I recently read. Almost 212 annotated structures have been identified in the brainstem. Yes, from a no man's land in the Cushing's era and considered to be out of the surgical realm, we now have got as many as 14 safe entry zones in the brainstem, 4 in the midbrain, almost 6 in the pons, and another 4 in the medulla. But yes, we must understand there is no region in the brainstem which is truly safe entry zone for the entry into the brainstem, because we do have a high rate of temporary but real deficits happening in the brainstem tumor surgeries. We need to do a thorough planning on, besides the approach, the detailed study of the brainstem has to be taken. The relationship to the surrounding vascular and the cranial structures has to be considered. And how the tumor has distorted the surrounding anatomy has to be noted in doing the preoperative planning to improve the outcomes in these surgeries. As on today, while I'm speaking to you, most of the centers all over the world, they do have access to intraoperative neurophysiology, good amount of access to the adjuncts, which includes fluorescein intraoperative MRI and the fine instruments. These are the child with a large grossly exophatic midbrain pontine tumor. And of course, we used all the adjuncts which we had at our disposal. And we could take out the tumor completely in this style, and the child woke up without any deficits. I think we must learn to talk to the anesthetist, the neuroanesthesia team, to have good outcomes, because a lot of times you come across anesthetists talking either about the patient going into brady and hypotension, and sometimes during medullary tumor surgery, patient may have hypertensive episodes due to various reflexes, anesthesia being light, and many other things. So neuroanesthesia support is very, very important. We do come across some good but very taxing tumors for the neurosurgeons, the large tumors wherein you spend a lot of time in taking out this tumor. But yes, we use intraoperative ultrasonography, intraoperative IGS, and navigation assistance and different positions to take out these tumors completely to inflict the minimum deficit in these patients. And sometimes we do come across huge midbrain pontine medullary tumors going into the peduncles, wherein we may need to take a combined approach, a retrosigmoid and midline suboccipital telovelar approaches to take out these tumors completely. This child had a very large tumor, and you can see the tumor was taken out completely in the child in 2 stages. This is another child. Sometimes you come across recurrent brainstem tumors. This child was initially operated elsewhere and was presumed to have DMG, but later on the biopsy came out to be grade 1 astrocytic tumor. And the child came to us, and we went in again, and we could take out the tumor safely using a combination of all the adjuncts of intraoperative neuromonitoring and fine handling of staying in the intratumoral planes and staying away from the eloquent zones or the safe entry zones in this patient. We could take out. Then the child woke up with some deficit, transient right hemiparesis, but then the child improved at 3 months follow-up. We do have some not so good tumors, and these are the ones which we talk about, so-called. Now they are called as H3K27 altered, which do have got 3 different subtypes of mutant, aberrant overexpression of SZIP and EGFR mutations. And in these tumors, I believe there is some role of biopsies, especially more so when you're planning for confirming the DMGs or picking up those genetic alterations. And in case your center has got access to some clinical trial eligibility. And sometimes in India, when we come across some atypical history or atypical radiology presentations or some inflammatory conditions, there is some role of biopsy in the brainstem lesions. We do use frameless biopsies, 4-core biopsy we do in these tumors. And few trials have come up now talking about the CAR T-cell therapies. Again, the biopsy is needed, but biopsy is not completely smooth always. There have been some reports wherein some transient deficits, some morbidity to the tune of up to 10% has been described. I mean, a lot has been talked about the patient improving outcomes, but what about neurosurgeons? I think intraoperative events, they lead to extreme stress, and it does affect the dexterity and the skill and the cognitive process of the neurosurgeon. Of course, your intraoperative stressful movements, they lessen with experience, but neurosurgeons do have some fears, especially in the initial part of the surgical career, of the loss of patient's life, inflicting some morbidity on the patient, medical legal litigations, And of course, the professional reputation of the neurosurgeon or the self-esteem being affected in case some intraoperative events happen. They do have some episodes of palpitations, diaphoresis, and shoulder girdle pain during operating. Believe me, it's true. It happened. It has happened to all of us at some point in our surgical career. There is no way that we can run away from the situation. There is no vent in the operation theater. The young trainees, how to handle the stress. There is no training courses ever held or simulation practices for the young training. They usually learn by how their seniors react or handle with the stress. And yes, most of the procedures, they are very highly stressful with less reward. And it has been shown to improve the cardiovascular mortality in these outcomes. At my institute, we did a beautiful study a decade back, wherein we actually looked for intraoperative pulse and blood pressure recording of the neurosurgeons was taken. And what we found, the episodes, the percentage of episodes of severe hypertension, to the tune of more than 180 by 110, they were almost quite higher as compared to during exercise. And this was a very, very significant finding, which we often tend to ignore. So what I do in my practice is I play a very soft background music, audible, which is low, medium volume. And in fact, Mozart's study has recently been carried out in I think, in New Zealand, and wherein the authors made the similar observation. And my residents also play some very soft music during surgery. I often practice and tell people you should breathe slowly, and during those stormy events. You should do a proper pre-surgical planning, and you should do a mental rehearsal of all the surgical steps. Have a teamwork, good communication, good contingency planning, backup should be there. And whenever there is a complication intraoperative, something wrong picks up, or the physiologists tell us that the MEP have dropped completely, disappeared, just stop, stand back, reassess, and negotiate your actions. And you need to identify your stresses during surgery. One need to focus on the goal, not on the outcome of the surgery, as the most important thing I personally believe. You need to silence your internal stress. Never make your stress manifest externally, because I believe one surgeon can stress 15 other OT staff. And night before the surgery, take a good sleep. I think good sleep, both for the patient and the neurosurgeon, is of utmost importance. Stop all distractions temporarily during surgery. And the last and the most important thing I want to talk about, kind of having an integration of three basic principles: the power of grit, wherein you learn something so as to reach to a masterly level, and to reach a state of flow state, wherein everything happens in a very flowless manner, and you have got complete command over the neurosurgical operation which you are doing. And then you reach a stage of mindfulness, wherein you actually focus on your plans or your action of the surgery basically all these three principles, they are interchangeable, they go side by side together. And then whenever there is any problem, I think you need to talk about focused breathing and stay focused. The last two slides, I mean, this is my personal take and my belief that, many of you must be knowing that brainstem is of the size of a thumb. The thumb has got impression, which is like loops, whorls, and the arches. And this made me believe in one basic important kind of a thumb yoga or a mudras to distress yourself during surgery. And while putting on those surgical gloves, you can actually do this Gyan mudras, Pran mudras, Prithvi mudras, Vayu mudra, and the Surya mudra. It can actually de-stress you, and it can also for exhausting long surgeries, I often practice these kind of things during my routine neurosurgical operations. And of course, the control on the breathing is extremely important while you are practicing the surgery. A disclaimer, do you need to stay calm only during brainstem or glamour surgeries and not in others? Absolute no. I think one needs to stay calm in most of the neurosurgical or the complex operations which we are doing. Thank you so much. And I think since I have finished in time, so may I request Dr. Mahesh Karandikar to join and to talk briefly, just 5 slides, about meditation with the permission of Professor Imad.
Hello. Good evening, everybody. Taking it forward from what Dr. Deepak has said, this is a very long and important topic, which is a topic of one full lecture. I just spoke on staying calm while doing neurosurgery in eloquent areas with the title Microneurosurgery as Meditation. Neurosurgery requires highest level of motor skills, and it essentially involves a unification of intellect, mind, and action. Intellect involves knowledge, skills, the whole programming, and your preparation regarding the surgical approaches and the rehearsal which you do the previous day. But what keeps coming in the way many times is the subconscious thoughts. The thoughts might be related to wards, related to ICU, related to your office, related to preparation of surgical instruments. Particularly, the mind sometimes is so bad that earlier failures keep popping up when you are dealing with very challenging tumors in eloquent area. The pressure of success also keeps mounting. All this is called vyuthana in yogic terms. And the solution to jump over this jumping monkey is called nirodha. And the dynamic equilibrium between focus, defocus is the goal of maximum efficient motor output and developing very superfine neurosurgical skill. Yoga essentially involves connecting the mind and intellectual abilities for optimizing the motor skills while doing neurosurgery. And it involves three main steps. One is dharana, which is concentration. Try to fix your mind on the surgical field. The second one is meditation. When vyuthana thoughts keep coming in your mind and keep disturbing your concentration, keep them away. And the third is, if you are able to successfully keep all those thoughts away, then it is the stage of deep contemplation where you become unified with the surgical field, forgetting the rest of the world. And mind you, this has got tremendous scientific basis. This paper published in 2021 explains an exceptional degree of electrocortical stability while doing yoga and meditation. And if you're able to achieve this during surgery, then outstanding results can be achieved. Now, how do you do that? The best way to do that is to prepare yourself for this concentration. One yogic technique mentioned is candle gazing. In yogic term, it is called trataka. Another one is chanting of Omkara. A lot can be talked about Omkara itself with various ways of chanting Omkara like Plut Omkara, Nyuk Omkara, Upansha Omkara, and Manasik Omkara, and so on. But friends, this needs repeated practices every day. This cannot come overnight. And this practice involved great sincerity, commitment, faith, and perseverance. Like we have been trying to teach opening up of Sylvian Fisher to young neurosurgeons, it can certainly not come overnight. Same thing about dissection of temporal bones in skull-base surgery, cannot come overnight. So yoga and the yogic practices have 8 essential steps. Therefore, it is called as 8 limbs
Professor
of Patanjali Yoga.
Mahashi and Professor Deepak. It's a beautiful presentation, but there are speakers, they have other duties to go and finish. So let's finish the program, and perhaps you can, at the end of that meeting, you continue your slide, because I'm seeing it's more fun than 5 slides. It's a nice topics, and we should not squeeze it this way, because people, they have to finish their duties at the hospital. So we will go back to the program. I apologize. And we will ask the next speakers first on the program. And then after the 2 speakers, we will have the joy to conclude with your presentation. Okay?
Fine. Thank you. Yeah.
So, Ek?
Thank you.
Sorry, my throat is so bad. Can you please take on for a moment?
Okay. Okay, the next speaker is Professor Bodji, is well known to all of us. He's going to talk about the I think hemispherictomy and disconnection for epilepsy. He has the vast experience We are blessed to have him with us on the this IANA and with our team. Giovanni?
Yes, do you see my screen?
Not yet.
No. So I try to excuse me, but I'm not so okay. I have to on the okay. Is the option? Yes. Zoom. Sorry, I tried to do it before, but
Do you like to have a few minutes and let's Henry?
yes, I
go
think
ahead?
that maybe
Okay.
Schroeder can go ahead and
Well,
I try to make the connection.
all right. Henry, you mind to go ahead with your presentation?
I try my very best.
Eddie, so you're not the last one. I will be the last one.
Can you see it?
Because the last is the best. So Giovanni is the best. Not
Yeah,
Henry.
that's why he wanted to.
Henry is not staying calm. He is with his Lamborghini and his David Hamilton on the speed. So the podium is yours, Henry.
Yeah, thank you for the kind introduction, and thank you for inviting me again. I'm always happy to see my friends and discuss. Can you see my slide, navigation guided tube-based assisted resection?
Yes, go ahead.
Okay, I just wanted to give some notes where we found the tube-assisted resection quite useful. Initially, I used it mainly for the colloid cysts, but nowadays we also do other indication. So what is the main indication is interventricular lesions and deep parenchymal lesions. So the tube approach, we use the side view from Weiger. There are 3 different sizes and 3 different lengths. Usually we take the 5 or 7 centimeter long, and then there are different diameters. 12 and 8 is what I prefer to use, but there are also larger ones going up to 21. But this is too big in my opinion. But 17 to 11 we use, or we use these 12 to 8. And when you make an MRI after surgery, you see it is really a very small tract. Usually we use navigation to have the ideal trajectory to the lesion, especially in tumor cases, but also for interventricular cases. So the question is transcallosal better or is the tube better? There is a lot of debate. Of course, transcallosal has the advantage that you don't cross any cortex. You just go through the corpus callosum, but it's more complex. You have the veins. It's more time consuming. And when the ventricles are large, I think the tube is a good alternative. If you have very small ventricles and you have a midline lesion, of course, I also use the transcallosal and I would not use the tube. And then the question is, should we use an endoscope in the tube or should we use a microscope in the tube? And this is also a kind of philosophy. When you use a small tube with 7 millimeter at the tip and you put a 4 millimeter endoscope in, then you have almost no space to move. That's why in most of the cases I take the microscope. When I want to look around the corner, then of course I use the endoscope to have a better overview. So both I think are okay. There are some examples where we discuss what to do. This is a lesion at the frontal horn on the right side, and one is here at the foramen of Monroe. And we have a hydrocephalus, and we want to have the histology. So what we use in this case is, of course, is not a tube, but just an endoscopy because it's small. We take a biopsy, we make a septostomy, and then you see we have a reduction of the ventricular size, patient improved, and then it turned out to be a lymphoma and was sent to the oncology. So another patient, we have a small lesion in the frontal horn on the left side, is asymptomatic, but in the follow-up it was growing. The patient want to have it removed. So what is the best approach? We can go transcallosal as an option, or we go transcortical. And that is what we do in most cases. We try an endoscopic and pure endoscopic approach. You see here is a lesion that's not very much perfused, and it seems to be attached to the head of the caudate nucleus on the left side. So what we do in this case, we go in with an endoscope, and then you see the tumor is not very well vascularized. That is ideal for endoscopy. And when we see that the endoscopy will solve the problem, then we stay, of course, with an endoscope, and we don't switch to the tube. You see, at first, what we do is we detach the tumor from the head of the caudate nucleus. We don't make a piecemeal resection because this takes a long time. So we just disconnect the tumor, and then we take the whole thing out via the cortical tract. So hemostasis is done with bipolar coagulation. And then you see the tumor is not fitting through the endoscopic sheath, so I have to remove the whole system to get the tumor out. But then you see it's very fast. When you make a piecemeal resection with an endoscope, of course, people criticize that it's too time-consuming, and they are right. So sometimes we have another case that looks similar, not very well perfused, a little bit dilation of the left ventricle, so we come from the left side. So I go in with an endoscope, you see it's more red, and you see much more vessels. And we want to have a good resection of this tumor, so we start with coagulation, bipolar coagulation. And then you see with each bite, it bleeds a lot. So we take it out, we make hemostasis, we take it out, hemostasis. It was not good. Then we make a dry field technique. That means we remove all the CSF and we look into the ventricle with an endoscope. And then I try to remove it with suction and with forceps, but it was not effective. And in this case, now I come in with a tube. It's a small tube with 7 millimeter at the tip. And then we can have the normal microsurgical dissection. I have a bimanual technique, traction, counter traction, and then we can remove the tumor over the tube. We have here the septum. We can dissect the tumor very precisely. We make a septostomy, so we have a good communication to the other side, and we remove the tumor from the septum, and then on the other side from the head of the caudate nucleus, and we can nicely preserve the fornix, that's a foramen. You see, this is bimanually done in the microsurgical technique much better than you have a channel endoscope and just pull on the tumor. So for these cases, I think the tube is much, much more effective, much better. The hemorrhage is not a problem. And you see here, this is a track. It's a little bit larger than with the endoscope, but still good. And I don't know how many years after surgery it is now, but she has no recurrence. I think at least 8 years or so. Another case is a 35-year-old female with headache and had an epileptic seizure. And you see an iso-intense to CSF, iso-intense lesion T1, T2, so very suspicious to be an epidermoid, proven by the diffusion-weighted images. What is the best approach? Of course, we should be in the longitudinal axis of the tumor if possible. So our approach comes here from the parietal region, small marcation of the incision, of course, with neuronavigation. And then we go in and we remove it initially with a microscope and later with an endoscope. So the tube is inserted via navigation, guidance, the trocar is removed, and then we are directly on the tumor. Of course, you could start now also with an endoscope from the beginning, but I think that this doesn't matter because so easy. You see it in front of you and you can use the space of the shaft. And then I use a 30-degree endoscope to remove tumor, which is on the side. You have to be careful with the veins, otherwise we can remove all the tumor and we get a near total resection left a little bit of the epidema, which was very adherent to the vein. And what I always do in the ventricular approaches is that I close the cortical incision with fibrin glue to avoid that we have subdural effusions. And GSO, now you see a small remnant here in this area, otherwise all is removed, and so far we have no recurrence. Another case is about a 39-year-old male, headache, nausea, vomiting, was a Deep Purple fan and Led Zeppelin fan, and we talked a lot about hard rock, but he came with this mainly interventricular lesion, but you see here, obviously he has edema on the left hemisphere, so it may arise from the brain tissue here, but it's mainly interventricular. So what is the best approach of this tumor? We thought we come from the right side, go in here, and then we end up on the left side in this area. And because the ventricles are not dilated, I think the tube is a nice idea to come. So again, with navigation, we inserted the tube directly into the ventricle. And then we start to resect the tumor. This is a little larger tube because of the size of the tumor. And then here you see it's too short. I have to make a longer one. We had only the 5 centimeter long one that was then too short. So we have to switch to 7. And you see the grayish tumor looks like a glioma. You see the normal wall of the ventricle. And then with ultrasonic aspiration, stepwise the tumor is reduced in size and resected. And always here we have our landmarks. Here you see foramen of Monro on the right side with fornix. Fornix was not involved. Could be separated very nicely. You see here, by Mendel technique, traction, counter traction. Tumor is dissected. Sometimes it looked like a very well delineated tumor, like a benign tumor. We could dissect it very nicely from the ventricle wall. Again, ultrasonic aspiration.
ना ते कनेक्ट झालं सगळं चांगलं आणि माझं त्यांनी शेवटी ठेवलं होतं ना.
Hello, please mute yourself, and then the tumor is removed. And this is a result we could achieve. Looks quite good. Maybe here is a little bit of tumor remnant, but otherwise was good. Unfortunately, it turned out to be a GBM, and in 8 months later, he came back with this recurrence. We did another surgery, but finally he died, unfortunately. Then that was a lady from Ukraine, 20-year-old female, hemianopsia on the right side. She underwent a stereotactic biopsy in Israel, and it turned out to be a polycystic astrocytoma. But they were taught it is inoperable because the tumor goes here into the basal ganglia close to the posterior limb of the internal capsule. And obviously it is the optic pathway glioma because she has a complete hemianopsia. So what is the best approach on this side? The left side, here's the tract of the biopsy. So which way should we come, from the front, from the back? So we thought the best might be we come here from the lower temporal area. You see here very well delineation. So our approach planning was to go very basal and go here through the temporal, inferior temporal sulcus to go to this lesion. And then because also deep-seated, we use navigation and the tube through the inferior temporal sulcus. Here, this is for Michael Skouras, this parcellation. He came to us for planning of the approach because he said there's always language. So we came from down here directly into this area. And then during the surgery, we reached all these margins so that we had good feeling that we have a good resection. So we go into the tumor from this approach, and you see this is a white tissue, and then you see nicely here, it's a gray glioma tissue. Was a good differentiation between the tissues what we have usually in polycystic tumors. The tumor was dissected with grasping forceps and ultrasonic aspiration. And the tube, you can angle it, you can look up, you can look down. So with this, you are very flexible, and the hole will not become larger. When I was assistant, when we had these metal spatulas, and always the approach was at the end much larger than initially. So I think the tube is, for these purposes, in the deep-seated area, very nice to protect the normal brain. And then you can bring it out, and you see it's very, very small opening. And then again, we put some glue to close it, to prevent the leakage. And this is the resection what we had. We left a little bit tumor behind the basal vein of Rosenthal's here around the midbrain on the medial side, because the vein started to bleed, and I don't want to occlude it. That is part what is left, but otherwise she's doing fine, and she is now, I think, 5 or 6 years, I think 5 years after surgery, and you see that she has no recurrence so far. This tumor remnant is stable without any radiation. And this is our approach. This is another patient, hemianopsia, just an example. It was a GBM operated by my co-worker, Dr. Baldorf. He did a fluorescence guided resection, and you see complete tumor resection. Or another case, you have here an intraventricular meningioma, which could also be resected with a tube approach. And you see there is only a minor disruption of the cortex. But the best, of course, is this case. You see a small tumor and the entrance of the aqueduct, very small ventricular dilation. What is the best approach for that? Of course, this is purely for an endoscope. So when we have this lesions, which is rare, so small, of course, we come here, navigation guidance, we go in. You see, we come in direct view. In 5 minutes, we are in front of the tumor, no dissection of any planes. This is the mesointermediate. You see the roof of the third ventricle with the veins and coral plexus. You see the habenular commissure, the pineal gland, posterior commissure. So the tumor is attached directly in front of the aqueduct. Then we bring in the working sheath. We go into the sheath to see the margin of the endoscopic sheath to avoid damage to the structures. We push the mesointermediate down. You can also cut it. It's not a commissure. You can cut it. It's no problem. And then we resect the tumor piecemeal with a grasping forceps. Takes the tumor out. There's also a kind of tube-based approach, but of course with an endoscope. There's a small remnant here. And then the tumor is completely resected in a very minimally invasive way. This, of course, is the ideal approach. Unfortunately, most of the tumors are larger. That's why the tube, in my opinion, is a nice alternative. So I strongly recommend the tube if endoscopy is not working well. For cholecysts also, we go in with an endoscope. If we see it's not working, we don't hesitate to replace it with a tube, and then you have a bimanual dissection if you have a content which is not easily aspirable. For these cases, I think the tube is very nice. Thank you for your attention.
Thank you, Henry. It's a wonderful presentation. It reminds me is a renaissance of Pat Kelly's 80s.
Exactly.
When he used that's tube. And I was inspired by him when I was, that time I finished my training in Germany in fellowship. And then I start using the pituitary speculum to do that. It was not as what he showed. And the modern technique, what you are doing, it looks like a full tube, not a retracted tube that it open like this. So it will be inserted. The other advantage of what you are using, it does not cut fibers, it displaces fibers. Rather than the other speculum and retractors, it cuts into fiber. As you said, if you put 2 small retractors to reach this tumor, that will be an additional very approach injury to the white matter. The complementary, what you have added, is the endoscope. At that time, we were using the microscope for that tubing. But it is a wonderful technique, and I am fully support this one. And the next case I have a smaller lesion like this, I will go for this, because this is what we now use to take hematomas. Hematomas, the best way is using the tube. I want to ask you, the tube, is it a glass, transparent, or is metal?
It's plastic.
Yeah, that's what is the advantage. This is another advantage.
It's translucent.
Yeah, you can see the surrounding while you are inserting the tube.
Yes.
Where all other speculum or whatever you want to call it is masking the surrounding. No, this is a great advantage, and I commend you. For hemostasis, do you use a flow seal?
No, usually not. Bipolar coagulation, and then sometimes I take Tabotam or Surgicel.
Tabotam, yeah. Okay. Flow seal is a nice material as well, but if there is a clear bleed, the best is Tacosil or Tabotam, whatever you are putting.
Yes.
Any other comment or question to Henry? Yeah, please go ahead.
Just wanted to say, I want to comment on you using flow seal. So I recently presented a spectacular complication at Keki's meeting where I used flow seal in the CSF, a different case, pituitary, but the flow seal did run down the clivus and then clotted and expanded. And the patient ended up with all sorts of cranial nerve deficits for 4 weeks until this whole thing dissolved, right? So I would not use flow seal in freely floating CSF just because you don't know where it's going. And if you use it very sparingly. I do like the retractor technique that you said. Ideally, you would have some form of a funnel that can be sort of cranked open gently, right? Because the idea is not to put in a big tube into a small space. So maybe you can briefly comment, Henry, how do you pick the size, or do you sequentially dilate the pathway until you have the tube of best usage?
No, I always take the smallest one, which I think I'm able to get the job done. So when I have the endoscope first, I usually take the 7mm one and just follow the track. So it displays it as laterally. This is what I do. I don't dilate. So I don't have a system which dilates and make it larger. No.
One more technical note for Ek about flow seal. I don't use the free lens, just inject it and leave it. I put a few drops on the oozing area and put the patty on it. So it won't be dislodged. And 1 minute, 2 minutes, and then you irrigate it. You don't just flow it in the CSF to go everywhere.
Yeah.
So this is another technical note to be considered.
Ek, how many liters did you inject that you have this cranial nerve palsy?
So it actually was, I tell you what it was. It was a pituitary case. It was me and my fellow doing this 10 years ago. And then there was a CSF leak from a heavily adherent tumor that was very dense. And we just didn't realize how much CSF, how much flow seal was injected into the pituitary fossa. So it went straight. He must have put the injection right on the CSF leak, and it went just behind the cellar, right? So it's a completely different case. And I would say 3-4 cc's. I don't even know how much, but you will all see the case. It's going to be reported in Keki's archives. It's a remarkable case. I'm not using this anymore in pituitary surgeries.
But for pituitary, is it good when you have bleeding from the cavernous sinus? Then it's ideal because you can really fill the venous.
Exactly. Put a little bit on the side and pack it with a patty, just as Imad said. That's perfect. But you know, you'll learn most from your last mistake. So that's thank you.
Now we go from the best to the last. Do you hear this, Henry? The best for the last will be
that's why he made the problem to be the last. I know that.
Yeah, Giovanni asked to be the last because he will be.
Okay, I try to
open share your presentation.
No. Wait, I try with the other computer, because with this one I'm not able to do it. I come, just a second. Okay. Here we are. Okay, I try to get. Okay, you see it? You see my screen?
No. Did you open your presentation?
And Giovanni, only one microphone on, otherwise there will be feedback.
So this computer has a microphone that is not. So this computer has a microphone that is not so good. You see, you hear me? You see, you hear me?
We hear you, but we don't see your presentation. Did you open your presentation on the computer?
Yes.
Now.
Yes.
You are coming.
Now
Okay,
you
we
see?
see it.
Now you see?
Yeah, just go into presentation mode. You see the upper line, there is like a couple
Okay,
of pointers.
okay. You see it now?
Yes,
Okay.
maximize the screen.
And you hear me?
Yes, we hear you.
Okay.
Maximize the screen.
So let's try to go finally to get this. So after all this, there is a kind of noise down anyhow. After all this surgery in which something has to be taken out because it's pathological, the disconnected surgery is cutting what seems normal. And that is something very, very particular. So the principle of epilepsy surgery is to have the symptomatic zone that you can get out of the analysis of the seizure, to get the epileptogenic zones and the surrounding irritative one. So,
Giovanni, can you make it full screen mode?
Giovanni.
Yes.
Can you make it full
I'm calling
screen?
you. You just opened the screen.
Yes.
You see that square. What did you? Why you clicked on?
You have to
this?
reshare again. So is the presentation
Share again. Share again.
Reshare.
Because yeah.
You see?
Share down.
And then
you see
the
that
bottom
box
yeah.
next to the X. The box.
Yes.
Click on it, so it will be maximized. I think you just go for continue with your slides. Okay.
You see something or not?
We see.
You can see it. Don't close it. But if you come
close
down
it.
to the
Yeah, this one. Click on this.
Forward that one.
This is better.
Okay.
Okay.
This is fine.
So this is the evaluation for surgery of epilepsy. You get the clinical symptomatology, the MRI lesion, and the EEG localization. That's are the things that are very important. And one has to be remembered that MRI is something that gives you the anatomical situation, but you have also to have a metabolic situation. That is the PET study. And the surgery of hemispherectomy is to preserve, to take out the pathological hemisphere and to save the other one. So it's a kind of very aggressive surgery in terms of anatomy. So there is a period of disconnected surgery that is going from beginning of the surgery, that is the tumor period till the functional hemispherectomy, and we will go very fast on that. Then the anatomic hemispherectomy for tumors. That was really taking out half the brain. This is was done in the recent year for hemimegaencephalopathy. You see here the MRI of this patient, and you get after the hemispherectomy what is remaining. The big problem of this, and this is the cavity. The big problem of this kind of surgery was the complication. As you see here, they are quite, at least half of the patients have the angle 1 that is seizure-free without medication, but the great complication was hemosiderosis that was not coming out immediately, but some years afterward. And that is something that is making the patient worse, till sometimes to have a death or fatal complication. So this in the early 70s bring this type of surgery out of not spatial but utilization. And there was modification of that. There was anatomical hemispherectomy and hemidecortication that you will see what it means, and functional hemispherotomy, that is something that we have to talk today. Functional hemispherotomy, there is a very difficult type of cutting out the wrong part or the pathological part or the part of the hemisphere in which epileptic foci are present. And this is the Delalanne transventricular one. There is Delalancourt, the transcallosal one, something that we heard today for other pathology, but that can be used for this approach. And the Villemore was disconnection from a lateral and a transventricular one, and this is the one that I was using, and I'm still using, and you will see the results. Schramm proposed another one passing through the Sylvian fissure and getting, let's say, the more Yashagri type of lesion using the system. Some other each group of neurosurgeon that is involved in epilepsy surgery use some variation of that. The hemispheric anatomy, hemispherotomy, you see here, means taking out of a part of one part of whole or part of the lesion of the brain in which the epileptic foci was discovered through the ACEG or magneto EEG. But that is something that is still remain in few cases to have a disconnection. What does it mean from an anatomical point of view? One is to disconnect the posterior part through the splenium, the anterior part, that is interior commissure, and of course the temporal lobe has to be taken out. It's a kind of a lobectomy that is going through. And finally, when the insula is exposed, you have to do an undercutting, because otherwise the seizure that the pathological activity, neuronal activity, can cross again the border and go on the hemisphere. So this is one of the view that you can see in the during the surgery. That means that is a part of removal, and mainly is a kind of section of fibers. And you will see this is one of our slides, but that was let's say taken out from the Rasmussen series. Results, Montreal series, you see here 86% of control. This is our experience that is not different from the other group. The indication, indication is very important because you have to be aware that you are cutting out something that seems normal, but normally is not, because seizures are not visible like tumor. The other one of the main problem is the blood loss, because usually this kind of surgery is performed in young patient, sometimes in adolescent, sometimes in the pediatric age. The indication, the malformation of cortical development, perinatal stroke, Rasmussen encephalitis, and Stuber-Weber disease. These are the main indication. The problem is to have the unilateral foci, not the, and sometimes you have this abnormality on the other side, maybe for kindling, but it has to be sure that from a semiological point of view, the foci stay in one hemisphere. And the disconnection is very important, and that you have to remind to the patient, to the family of the patient, that neurological deficit will be present and acceptable, because you are cutting the pyramidal tract, and at least immediately after the surgery, the hemiplegia may be present. Not always, and that is something that is astonishing, if you want. The surgery has to be done early as possible, because to prevent the intellectual deterioration, then we know that pharmacological medication is not helping these children. EEG is very important. I go very fast. I don't know if it's not necessary. One thing that may help during the surgery is the evoked potential, because can guide you as all the intraoperative monitoring. Of course, as you said before, we have to be sure that there is an alteration of metabolic alteration, and there has to be only on one side, because MRI is showing the lesion here, but sometimes you get also contralateral disturbances. Peri-insular means that this is the first course, this is the way you are performing the disconnection, as you said before, posteriorly and anteriorly, and afterward you take out the temporal lobe. Navigation is mandatory, of course. DTI is very important, because they can give you the position of the fibers that you have to cut, but also to try to avoid, and for instance, the posterior part, to avoid the damage of the occipital organ. The indication, I said before, any megalencephalopathy, chronic encephalitis, Rasmussen syndrome, that can be in multifoci. Again, another example of see on the MRI and on the PET. This is the findings of the that you can find out after the hemispheric. The middle cerebral artery stroke, that is is not often, but can happen at birth, and in these unfortunate children. And this is the hemispheric dysplasia. It's a kind of not yet recognized genetic disease, but it's something that can really completely affect the evolution of the children. And sometimes come out later on, and that is the only indication for adults to get disconnection surgery. Stuber-Weber is another problem, although now radiotherapists claim that can be reduce the importance of this disease in terms of epilepsy. As you say before, this is the pathway and the disconnection that you have. And you see here is an anatomical disconnection, and you have to know very well the anatomy, and MRI can help you, navigation can help you, but you have always the opportunity to check more and more step by step where you're making this connection. And I will show you what are the big problems, because posteriorly disconnection is very easy. Anteriorly in the communicating arteries and in the frontal lobe is not so easy. Again, another type, another example. The main question is, I show you that in the past there was anatomical hemispherectomy. Today we're using functional hemispherotomy or hemispherectomy. And these two completely different techniques are getting different results. The answer is no. There is no, the procedure is similar, although the functional hemispherectomy or hemispherotomy brings a better result in terms of quality of life with the patient. But of course, there is no randomized comparison, and it's impossible to do it. And I think it's unethical to do it, so we remain with question mark. The outcome is good for in terms of the different etiology, and the answer is that that dysplasia and encephalopathy are better outcome in comparison of the other indications that I told you, following the different series reported in the literature. Complication, is it possible to make omelets without breaking eggs? The big complication is bleeding, aseptic meningitis, and the hydrocephalus. These are the really situation. The superficial hemosiderosis with these techniques is almost completely forget. This is the complication. Blood loss, you see, is not so easy, and you see here that 3 out of 20 bone, 2 out of 20 in Milano has to be transfused because of a loss, because they are children in majority of cases. BP shunt, we have no this kind of complication, but we have to be aware that it can happen. And sometimes you don't get a results of decision, and you have to go back and do again a surgery because of not complete disconnection. The outcome versus etiology, you see the supervagal megalencephalopathy as the best one, while this is the Cleveland series, and this is the other series, and you see here that the results are quite good in terms of Engel 1, that means no seizure, no medication. Reason of failure. The patient sometimes is bilateral, and this is the question of patient selection. We have to be very careful of that. But the major problem is anatomical one, incomplete disconnection. That is the most important case of failure. I say splenial remnant is more often, but the frontal lobe remnant is much more happen more often. Incomplete disconnection, you see here, complete posteriorly and complete anteriorly, and you see that in this case we never get in the frontal area. Reoperation, of course, in some cases we have to do it. And you see here the different series, Montreal, Baltimore, UCLA, and Cleveland. The possibility to have a good results are still present, although it's very difficult to propose to the family a second surgery after this major surgery. Etiology, you see here our experience. And the results with a follow-up mean of 6 years, 81% in Engel 1, and the other some improvement, and in 2 cases, no change. And the no change is probably due to the fact that the selection of the patient was not good, and the patient has a bilateral seizure foci. The advantage is the behavior that is completely modified, and also the psychological aspect, because this patient may go to school and get improvement of their learning, and the most important things that is improving memory, and in the quality of life is much more. Our complication, know that accepted meningitis in 70% of patients with this kind of symptomatology, fever, lethargy, and loss of appetite. It is, and of course, the CSF examination will bring to the final physiological score. Conclusion: disconnection is a procedure that should be proposed in case of single hemispheric drug-resistant epilepsy. And in our hand, the peri-insular hemispherotomy is safe and effective in control of the seizure with very light motorial deficit. But new technique may change completely the game. The possibility to have an exploration with ECG and surface recording, the possibility to have other things like vagus nerve stimulation and DBS may completely change the game, and being both of this technique, less invasive, the hemispherotomy, change completely the approach to this kind of unlucky patient. This is our team, and I thank you for your attention.
Thank you very much, Giovanni, for this the wide spectrum overview of the disconnection procedure. Of course, this is technically, perhaps we see it not very demanding, but is demanding if you want to incorporate the new technology in this. And I think you hinted to the most important part of it, early management of these before they become really refractory, and when it goes into atrophy and decline in major cognitive dysfunction. And as you said, using new technology is very essential, like what you have been DBS nowadays are used, and go into the more functional disconnection rather anatomical, but knowledge of anatomy for either way is essential, and that's what the IANA is for, to cover this part properly well. Any comment or questions to Giovanni? You cover it all.
Yeah, thank you. I hope that this presentation will not be the final of this approach to seizure, to surgery for epilepsy. But I think that one thing has to be taken in mind. Remember that alteration of the cortical dysplasia is very, very seldom recognized by the neurologist, and is the collaboration in between neurologists with semiology and EEG can bring completely different approach. And the other things is that there is another disconnection that I did talk because of the time, is that the temporal lobe disconnection, the cutting of the tail of the hippocampus. Sometimes if you have a insular or temporal lobe epilepsy, in terms of semiology, you can have a very good result. That is to be remembered. And it's a little bit uneasy for a neurosurgeon to cut something, a tissue that looks like normal, but that is the game.
Thank you. Well, before we close, just want to ask Professor Deepak if his associate is around to give the few slides as conclusion.
I think he's there. Dr. Mahesh,
Okay.
could you just complete your talk,
Thanks
please?
for
Yeah.
being patient. Go ahead, Dr. Masha.
Thank you, Dr. Imad.
Should I pick up from where I
Yes.
stop,
Yes,
or
please.
should I
Yes, please.
summarize?
You
Please
can
do.
just pick up from where you stop, please.
It depends how many slides you have.
The earlier I'll share. Yeah. See, to summarize, I said that intellect, mind, and body unification is extremely essential for any kind of skills, and neurosurgical, microneurosurgical skills are most important. The important points is concentration, meditation, and deep contemplation on the surgical field by the operating neurosurgeon. This is the scientific evidence of electrostatic stability on the cortex of any person who is operating for yielding maximum possible results. Now the question is, how do we achieve it? What protocols the ancient Indian sages and yoga has offered? There are many techniques. One is simple repeated practice of candle gazing. This is called as Trataka. If you focus on the light or the flame of the candle and try to unify yourself with the candle flame, then that dissociates you from the rest of the thoughts which can keep contaminating your consciousness. Another technique is chanting Omkara. Omkara can be chanted in various ways, and different ways have different effects. But again, the underlying principle is unification of mind, intellect, and body for achieving maximum fine motor skills. Obviously, like we do repeated practice of dissection of temporal bone for skull-base surgery or opening of sylvian fissures, as we keep practicing, the efficiency go on increasing. Similarly, the yogic techniques needs frequent practice with devotion and dedication. Now, to take it one step further, the fundamental principle what Upanishads offer on this background and the scientific basis for this, we correlate any thought to a particular activation of a neuronal circuit, which consists of activation of one neuron through synapse, second neuron, third neuron, and so forth. But the question which Kenopanishad raises is, what is the stimulus for activation of the very first neuron? Is the stimulation comes from somewhere beyond the brain? And if it is coming from somewhere beyond the brain, is it what is called as the individual consciousness? And probably the brain is an instrument of individual consciousness, which is beyond our body. And if you practice these yogic techniques with subject-object unification, then probably that corresponds to blending of individual consciousness with universal consciousness. And if you are able to blend with the universal consciousness, then probably additional faculties.
We are not hearing you.
Unique protocol.
Now, go ahead.
I think his Wi-Fi is frozen.
Have done lots of homework. There is lot can be offered by these days.
Ich kann ihn nicht hören. Könnt ihr ihn hören?
I think he got frozen.
I don't hear anything.
No, it is frozen. The picture is frozen. His picture, and I cannot see him talking now.
During operative surgery, and can give you a different perspective to go ahead and make decisions on table. Thank you.
Thank you very much. It's illuminating. It's always nice to have something additional, give a flavor to our presentation. Thank you for being willing to stay to the end and give your experience on this one. For sure, I'm going to look into this more in details.
I'm sure this has lots of things to do, but it is impossible to just put it in few minutes. So I have just tried to touch few things.
All right. Thank you very much.
Thank you.
Okay.
Thank you.
We need a
Any
course
other-
for this.
Any
I think we need a
comment?
course.
Henry,
Yes.
any questions?
Yeah, we need a course for this. A practical hands-on course, please.
True.
Yeah, well, wonderful. Okay, so perhaps Professor Deepak will arrange in the future some course for the IANA group on one of the events, a course and additional to talk about these situations, meditation.
Yeah, if I could speak for if I could speak for 30 seconds, I think we had excellent presentations today, but we as neurosurgeons, we often ignore our health. And, our machine gets older by 24 hours each passing day. I believe we need to take care of ourselves also, and we need to stay calm. And this thing is something very extremely important for all of us. Thank you.
All right. Well, thank you, everybody. Well, thank you for being here. And we conclude the session for next webinar.
Thank you.
Thank you.
Bye-bye.
Bye.
Take care.
Thank
Bye-bye.
you.
Bye-bye, Mad.
Bye-bye, Mauricio.
We are all the
here the
resident.
guys, the young generation.
Enjoy your speech and your teaching. So
They will compete
not
with
all the faculties, of course, but
most
your
of them.
organization.
We are waiting for them. They will compete with AI for sure. All right.
Thanks. Thank you very much.
Bye.
Ciao, Gian. Ciao.
Bye, everybody.